where you were, where we're going. And then we'll look at the injuries and the type of injuries that occur and the baseline management. That's part one. And then part two is Dr. Stoltz will come in. I think all I'm going to do is try to do an hour and a half-ish, and then she'll walk you the rest of the way through on the full-term management of these patients, basically in the acute setting, and how you're going to walk them through the ICU settings and stepping them down, okay? So I'm going to get them into the ER and send them to the ICU for treatment, and she is then going to show you how these patients are managed in those acute settings. All right, so remember, the patho, remember we talked respiratory and patho, do you guys remember that?
Yes.
No, you're lying. So anyway, we're going to do a quick review of those systems as well. So the class objectives, basically this is how it's going to roll out. This is the agenda. And then, you're going to have more content. Remember, the backdrop is the path and the anatomy and physiology is your backdrop, but that's already assumed that knowledge is already in place, but we're just going to reorganize it. So then you can be looking at your treatment and recognition and assessment of these patients and respiratory distress for whatever reason. So we'll be basically pneumothorax and the types of pneumothorax. We'll be talking the hemothorax, fractured ribs with chest, pulmonary emboli, and we'll just kind of wrap up talking about the acute exacerbations of asthma again. All right. How many lobes on the right?
3.
How many lobes on the left?
2.
Good. Now, with that said, when you auscultate, that's when you're going to be listening to patients who either have pneumonia or they have obstructions, they have a pneumothorax, a hemothorax, or whatever ails them. You should be listening to each lobe. For the record, a chest x-ray for like pneumonia and everything else is considered confirming, but not a diagnostic. Your auscultation and your ability to properly assess your patients should be giving you everything you need to know. The x-ray is backdrop. You don't look at the x-ray and then start to assess. You actively assess your patients. As it was known a couple of years ago, right? On The View, when Joy called it the doctor's stethoscope. If you have that mindset, drop slips are in the back of the room. That stethoscope is your tool, your toolkit on how you're going to take care of your patients. The physician's listening, that's super because that's their job. You better be listening too because you know why? It's my job. Correct. I'm glad you guys all got on that together. It is your job. I can tell you when I was in Houston and the chief, good guy, Dr. Maddox is a good guy, extreme top of the game, worldwide, world renowned, but he was a little misogynistic and a bit old school. When the nurse started listening to the chest breath sounds on a trauma patient, he said, you need to do what nurses do. Go get the card to stamp the forms. And then, of course, the nurse completely ignored him, as she should have, and kept calling out the assessment findings. And her assessment findings were a little different than the physician's, because it was rapid. Guess who was more accurate? No, the doctor. Much better. No, the nurse, of course. The nurse. I mean, because, they're just running through, because those are teaching programs. Remember, the residents have skill sets they're still developing. Now, residents, mind you, are physicians, but they're still learning their skill sets. So some of these nurses you can start working with in these critical care units are experts. They've been taking care of patients for a long time, so learn from them. A lot of these internal medicine docs that are new will always look to that real senior nurse and say, call me if anything changes, because they know that nurse that they do call them matters. So please maintain, especially as, you're going to be working without a net here sooner than later, right? You're going to be working with, a net sooner than later. So start to take that stethoscope and make that your assessment tool. Hands to that patient, auscultation to that patient, palpitation to the, percussing. That is what you need to do with these patients. Back to the 3 and 2 lobes. Those are all areas of interest. Those are areas of disease. Those are areas of obstruction. You should be able to auscultate that. You've been taught, but you have to be aggressive, the skill set. Just because you passed health assessment 400 years ago, it feels like, right? Does not mean you are really capable. It has to be a drill. You have to keep doing it and doing it and doing it. And then once you finally have your baseline, you got to do it again and again and again. I'm pretty rusty at this point. I mean, I'm good. I can still hopefully blow you guys out of the water. But the nurses, like when I ran the trauma center at BAMC, these guys did it 40 to 60 hours a week. I'd come in there, I mean, mind you, I had the same footprint at one time, but you have to stay current, right? How many people in here were runners in high school? Raise your hand. Okay, are you still a runner? Could you still run as well? Some of you, my whole point is, okay, so let me back out of that one. Who used to run but doesn't run anymore? But you know how to run, and you know if you're going to run again, it's going to take a lot of work and effort, right? So your health assessment skills, I just want to drive this home, a little soapbox, set the mindset. You are responsible for that patient, not the physician. The physician, of course, is responsible for the patient, but your practice is exclusively your practice. And you need to be listening to all your different lung fields accordingly and know what you hear or what you don't hear. You have to know normal, the specter of normal, and then you have to know abnormal, right? Smoker's lung, it's an autopsy, not an autopsy, but it's a cadaver. See the lungs of the carbon is just an exemplar.
The narrow passage of the nose slows down the rate at which we...
In the hill country in San Antonio, right? Who suffers from allergies, right? So what are those ridges in the nose called? Turbinates. Who said that? That's really good. Those ridges in the nose, why are they there? Because they allow more exposure, right? As they ridge, that creates more exposure of flowing air go through so it can be warm. Remember, air going to the lungs has to be warm. Who's from cold country here? Raise your hand. How cold? Canada cold? Oh, don't you know it? You wear a toque? Would you wear a toque up there? A toque? Yeah. So what about you?
Michigan.
Michigan, okay. I'm from Wisconsin. Canada, Wisconsin, Michigan are all same country. We're all up in the same neck of the woods for sure. So it's cold up there, and it is. Your nose hairs freeze as soon as you walk out, correct? When you spit in the middle of January, your spit literally will freeze before it hits the ground. You can take hot coffee sometimes, and it will vaporize before it hits the ground. Now, think about it. Your lungs then should freeze. No, they don't, because you use this upper respiratory, allows it to go through the turbinates, even though your nose is cold. By the time it gets to the back of your throat into your lungs, it's already at 90-some degrees temperature. This allows the blood flow to be available, but along with that also, the blood flow being available works also with your defenses, right? Your respiratory defenses in a healthy system. And you can see how smoking obviously can cause some problems with this ciliary system, being able to beat mucus up and keep it down and moving it through. So these are your first line defenses, and this is your upper airway, which is very, very important for warming and humidifying the air going to the lung. So here's a cross section that's showing a bronchoscopy. Piece of tape from this, the main bronchi. Who's been in an intubation? You saw one recently? In class or just, what? Okay, so what happens is, you see how they listen to both sides? When they acutely intubate someone, either in the OR, in the ER, in the ICU, you're going to listen right and left. Because of the anatomy, you're more prone, if you go too far with an ET tube, you're more prone to do a right side intubation than a left side. So you'll listen, breath sounds on the left, breath sounds on the right or left. But when you listen, as a nurse, you should be listening, and when the handle bag gets hit, you should hear in both sides. And if not, you're going to say only breath sounds in the right. So pull back a little bit, and then you'll listen again, breath sounds by left, okay? okay? Breath sounds bilateral, and then it'll blow up the balloon, and then we'll mark at the jaw where the ET tube is. So you can see a little bit, it's not always gonna go. Remember now, get used to gray. You guys are very used to yes and no answers. As you move forward in practice, a lot of gray. We have predominance. When you're intubating a patient, if you're gonna do too far, most likely it's gonna be a right stem bronchi. Does that mean it can never go left? Of course it can, but the predominance, so your bias should be set that you're gonna immediately suspect that, but also understand it can work either side. Things are no longer absolute in your world. So again, this is the pleural lining of the lungs. What is this? What is the function of this again? What is it? Speak loudly so I can hear at least one voice. Because I hear kind of almost apologetic, like noises. What is it for? Lubrication? Right, that's exactly right. It allows the lungs to expand and to drop without friction. So you're gonna have the lining. Now remember, it's like, you guys, are you old enough to remember latex balloons? Not just Mylar. Remember when you had your balloonie? Remember you're all happy about your balloonie? And then it starts to not the string's too heavy to even let the balloon float anymore. And it's kind of shrunk and you play with it a little bit. You can put, your fist into it. It looks like your hand's in the balloon. Remember that at all? Well, that's kind of what the lung looks like with that pleural sac. So you have a coating on the rib cage and another one around the lung. So when you breathe, it's filled with the fluid. You breathe and drop. Take a deep breath and let it out, right? Real quick. Did it hurt?
We lost.
Does it hurt? No. Now we'll tell you,
Steve's are mixed.
it can when you have an infection there, pleuritis. You get an infection. And so, who is it? Oh, sorry. So anyway.
It was yesterday?
Hey, Mom, stop it. Anyway.
That's the gym. Yeah.
But real quick, did you brush your teeth this morning? That's what you're asking. Okay. So, with that said, when you get the pleuritis, I had the flu. I got the flu like on a Friday. I was here in '93 for the officer's advance course. My buddy Kevin Forrest. We were washing our car. It was kind of a slow day. And my wife was at work, and we're supposed to go to the Doobie Brothers that night at SeaWorld, right? You know who the Doobie Brothers are? Yeah. Right? It's a are they dead or alive mentality for you guys. But anyway, I was pretty excited. And all of a sudden, literally, it hit me like a wash. It just felt horrible. And the dude, my buddy's like, "Could I have your ticket, man?" So I did. I had to give my ticket. And I just had to coil up, and I just had really bad shivers for like 24 hours, felt like crap, febrile. And then by Saturday midday, it kind of passed, right? Sunday, I was feeling, it was okay. Monday, back to work. And I was a little short of breath. So that kept getting worse and worse. Short of breath, short of breath. And at the Academy of Health Sciences, it's a third story. So I'm up the stairs, and all of a sudden the sweat's just pouring off. And I can hardly breathe. Now the room is filled with nurses. Your classmates are nurses and physicians and dentists. And everyone's concerned except me. And then I'm really getting short of breath, and the sweat's still pouring off of me sitting there. So they took me to the emergency room. Well, what happened was everyone thought I had a pneumothorax, which we'll talk about, but in reality, all I had was pleuritis. The lining, the pleural sac, got infected, and it sounded like sandpaper. You can hear patients with pleuritis when you auscultate. It sounds like sandpaper. You can hear the lungs dragging, and that's exactly what it feels like. When I did that real quick breathing, each breath felt like someone had sandpaper on my lung. It hurt. So you can auscultate pleuritis. So the patient will describe being short of breath. Now mind you, we'll talk, that doesn't tell you it's pleuritis. You work your way to that diagnosis, right? But you should be able to hear that. There should be an assessment piece. When you're listening, you should be able to hear the lung field without rubs. The auscultation, when you're assessing your patient, you should be able to hear a clean set of lungs. You should be able to hear the breath sounds in each lobe, and there shouldn't be no rubs. You may hear rubs, and it may be because the pleural sac is actually infected. viral or bacterial, okay? Now, we went through this in past, so we're going to fly through it, ventilation, diffusion, and perfusion. Ventilation is actually bringing the air in, the diffusion is getting the air to the point, or it's going to go from the lung into the bloodstream, and then the perfusion is the actual distribution of that oxygen and CO2 in and out of the system, right? Are we good?
When we breathe in, muscles between the ribs pull the rib
We
cage.
talked about that, what you just saw, a lot of times people forget, like NG tubes, right? First of all, you know, when people want to put an NG tube in, they think it's like this way, right? Remember, it's straight back, right? You know that. You do know that, right? It's straight back, not up your nose with a rubber hose. It should be straight back. So people also, the diaphragm, gotta understand, go like this again, like before you're having an exam, those of you that are spiritual, you say, okay, cross your hand like this, do this for me. And then take a deep breath, and as you do it, have your hands go straight out. And as you let the air out, go back like this. That's what your diaphragm's doing, right? It's relaxed, and then it goes rigid. And when that diaphragm and that disc on the base that separates the abdominal content from the thoracic content, that disc goes straight out, it lifts open the lungs like a billow. You know, anyone have fireplaces and stuff, right? The bellows, same thing. So it's going front, it's lifting up. Now the muscles, the intercostal muscles in between the ribs are lifting, and then scaling muscles in the neck, right? Those are lifting up as well. So when you're looking at a patient, but not without respiratory duress, you're not going to really see the air sucking in, especially in pediatric patients where they're pulling in, you won't see that. You'll just kind of see non-effort breathing. As patients start to have distress, discomfort, you're going to see the scaling muscles helping assist. Sometimes we'll show that later on, one of the videos of asthma tech, where they have to sit almost tripod just to breathe, right? Because they need to use the gravity, they need to use the muscles because they're exhausting. They need to use ancillary muscles to help with the respiratory effort. And these are all things that should be early clues to you as a skilled nurse that your patient's not doing well in some respect. Now, the compliance and elastic recoil. Do me a favor, please, take a deep breath and hold it on the count of 3. 1, 2, and 3. And hold, and now let it out. All right, so you're able to take the full deep breath, correct? Most of you, I hope. And then when you let it out, you have to force it out, or did it just go out on its own? Went out on its own, right? So there's your compliance, was allowing the air to go in, and then the elastic recoil was the lung collapsing down on its own without the effort. So, the radius of the airways, so when we talk about asthma in particular and bronchitis, remember that they get inflamed and the air gets smaller, more effort. Laplace's law, we'll talk about that a little bit. And then you should have very little resistance in the healthy lung model. Now, looking at atmospheric pressure. So at sea level, San Antonio is a little higher, but good on the corpus basically. Here too, for the most part, but the elevation is minimal, is around 760 millimeters mercury. And when you're just sitting here without taking a breath, it's neutral space, 760, 760. So when the diaphragm contracts, you can see in the second frame to your right, where it goes rigid instead of arched. That does. So all it has to do to get the lungs to fill with oxygen, it changes by 2 millimeters mercury. So it creates a negative pressure and allows all that air then to flow into the lung. The diaphragm creates negative pressure, and of course the air then will follow the negative pressure and then neutralize. And when you let it out, it wants to escape back out and then neutralize. So this is inspiration. So you can understand the models that we're going to be working, who's going to be moving to Colorado for whatever salacious reasons of moving there. But anyway, when you're working at mile high, that changes the dynamics quite a bit. Has anyone been in a mountain before at the tree level? You've been at tree line? At 10,000 feet, was it hard to breathe? It's hard to breathe. You know why there's no trees there? Not a lot of oxygen, right? So when you go there, so people live there, but again, that's where ET, you can have your body's going to tell you make more red blood cells, right? You need more iron, more red blood cells, your body will eventually respond, but if you go there, it's going to be harder to breathe. So So you will see patients in Mile High City and everything else are going to have different patterns of breathing based at it's going to change as far as the diffusion of oxygen. And of course, you would anticipate you would see their H and H changed as well. Now, what is their driver? We need the nervous system. Tells their body. So anytime you have a patient that has a head injury or any type of drugs on board, right? Obviously, you got to be thinking about this. Is that person going to be able to breathe on their own? Is anyone watching Dope Sick at all on Hulu? It's actually fantastic. I know I don't want to distract your studies and your opportunities for when you have to, however you recreate. But Dope Sick on Hulu is amazing because it's historically correct. It's about the Purdue family. But anyway, people are all hooked on Percocet, Ground Zero, especially where it started. Respiratory is the first thing that goes out on patients with the heroin and narcotics and opioids. So it's easy to turn around, Noxalone, right? You know that now. But, so respiratory, the drive, did you have to wake up last night and set your alarm every 20 seconds to wake up to breathe? No, you breathe on your own. It's an autonomic system. So you gotta remember, most times patients that are conscious and awake are going to be breathing just fine if everything's in alignment. But if there's anything to alter, including alcohol, can certainly change the respiratory drive. So as a nurse, again, you have to assess the complete of the patient as you're listening, and are they breathing accordingly? Are they taking full deep breaths? Are they too shallow? Are they too rapid? All these portions are something you have to look at, but understanding that the neurophysiology at this point dictates a lot of the quality of the breathing and how often and is monitoring the CO2 versus oxygen. So now we're going to give some exemplars of things. Now this is a little binary. I want you guys, when you study for this, to work accordingly, because you're going to have restrictive and obstructive lung problems. So we're going to talk restrictive disease processes first, and then we'll talk obstructive. Don't get confused when it comes time for examination. So, central nervous system issues, head injuries, patients that have strokes, narcotic and barbiturates, we talked about that. Then again, there's actual diagnoses of GB. What is GB? Green Bay, it's going to beat the Seahawks on Sunday. That could also be something you think of, but no. GB is what? Guillain-Barré, right? And what's the next? ALS. The quick way around ALS is called Lou Gehrig's. What's MG? Myasthenia gravis and MD. Okay, so if you know a patient has a diagnosis as such, especially like ALS, because you'll know that patient, especially if they're in a clinic setting, med-surg setting, you will get to know these patients eventually, ERs and the ICUs, because these patients eventually are heading towards a ventilator of some sort. So understanding the disease process is understanding also their ability to properly breathe is being hobbled by nerve issues, and some pathology is interrupting their ability to properly have respiratory drive. Now, physicality is the chest wall. That's the machine itself. Chest wall trauma, obesity. What's kyphoscoliosis? What's the layman's term a lot of times? Hunchback, right? Which we don't say. But that's what people would call it. And then pleural disorders, the actual tissue. Pleural effusions and pneumothorax are the damage to lung tissue itself. And then also the parenchymal is the tissue as far as ARDS, atelectasis, the pneumonia, and interstitial lung disease, right? That's where infections and everything else occur. So these are exemplars based on the nerve, the muscle, the machine, the pleural itself, and then the parenchyma, the tissue of the lung, are all part of the examples are of restrictive lung problems. Now, examples of obstructive lung problems. It's pretty easy. things that don't allow air to either get in or out, period, really. It basically blocks it from getting into the lungs. Now, the reason why I have mucus plug highlighted because there's a story attached to it. This story resonates to the point where I've had students come back to me 8 years later to tell me it finally happened to them. Are we ready for the story of the mucus plug? So, there I was, a young ambulance driver in college, and I had to pick up, I'll just say her name was Marge. I had to pick her up. She was on a breathing apparatus, and once a month she had to go from Sheboygan, Wisconsin, which is between Green Bay and Milwaukee on Lake Michigan, had to go to Madison. That is the home of the Wisconsin Badgers, my alma mater. But anyway, I had to drive her 2.5 hours there and an ambulance and drive her back. But those of you who in here is over 40 years of age, please. Okay, good. All right. Remember ambulances that used to look like hearses? Okay, that's what I was driving. It was a giant station wagon. Instead of being black like a hearse, it was painted white with a blue top. But this lady was of size. And she hated to lay on that thin gurney to begin with, much less in the back. And I got to know her pretty well. We got along real well. I was her regular transport, part of the ambulance service. And she always, hey, Cleveland, show off my hands. Hey, can I sit up front with you, please? I'm like, policy. I said, I really can't. Please? Okay, fine. So I let her sit up front with me. And we're sitting there, and we're kind of talking. And all of a sudden, Murphy is the reason why we have policy. And all of a sudden she starts going, and she turns blue, and her eyes are like bulging. I'm like, great, how am I going to explain this one? I won't get paid today, And she's like, nothing. All of a sudden, boom, out of her mouth lands a mucus plug on my windshield. And to help you with the visual, you know what cream of mushroom looks like in the candle can? It was like someone took a can and just splattered the cream of mushroom onto my windshield. Mind you, I'm going like 60 miles an hour down the interstate. She goes, I'm so embarrassed. It happens once in a while. I feel so much better. And she grabs tissue. I'm like, no, Marge. She starts to take it, and she takes her seatbelt off because it really worked hard back in the 80s. And she starts to wipe it. Now, I can't see. I'm all over the road, right? And the smell. You know what it's like when you have an animal in the middle of summer, and it's on roadkill, and you get close enough, you smell that? Add that to the dimension of my visual. Now it smells like death, and I can't see it. I had to finally pull over, and I literally had to use an ice scraper to make a window to visualize the thing. So, not to mention, I still didn't punish her, I didn't make her get back there. But, for the record, that is the story of the mucus plug. Now, students later that become colleagues when you graduate, you're my colleague, they let me know that they actually got hit by this foreboding thing that I was saying. You say, you think it's gross on your windshield? How would you like it on the side of your cheek? So they do let me know that they can up the ante of the mucus plug. The whole point of the mucus plug is, what is it part of? What is it? Obstructive, remember that, okay? The mucus plug is the obstructive airway lung problem. It's a big block of mucus that won't allow air to get in. Bronchospasm. When you're giving patients medications, it's really important to ask them if they have any allergies. Has anyone heard of bronchospasm in practice yet? It literally, there's two snaps. We kid around about this, but in reality, you hear click, and their airway will spasm shut. One patient, I asked her if she had any drug allergies. I was giving her 2 milligrams of morphine, push. And this is her second time getting morphine, which is the exposure, right? First time is the exposure, usually don't have a response, so she didn't legitimately have any allergies she knew of. So I was just giving her slow push at 2. And all of a sudden I heard, and she starts turning blue. And then there's and that was my orifice closing off, because I was in full panic order, because we needed to turn her around, right? She needed what? She needed epinephrine on board, we needed to get Benadryl on board, we had to get her breathing quickly or they're gonna have to do a cup down. We were able to break it pretty quickly, but the fact of the matter is when you hear a bronchospasm and it's on your watch, 2 clicks. One's yours, one's hers, right? So anyway, that's the bronchospasm. The airway literally closes off. And if you can't break it, they do have to do emergency trach on the patient. And there we talk about the endotracheal tubes. Also get those mucus plugs. That's why have you guys done the closed ET systems? Who's been in the ICUs to do the closed suctioning on the ET tubes? Right? It's pretty interesting, right? You gotta go in. At least it's a closed system now, but does it irritate the patient a little bit?
Yeah.
So it does, it irritates the patient a little bit, but you gotta do it judiciously. How long can you do the suctioning? Why? Not only that, what are you doing when you're saturating a volume? You could pull the residue, right? Remember, we have pulmonary volume. You can steal some of their tidal volume if you over-suctionate. You gotta make sure that the tidal volume stays within a parameter so you don't cause additional respiratory arrest. So these are all obstructive. And then, of course, asthma, and then chronic COPD, and emphysema. COPD and emphysema are in kind of the same neighborhood as far as treatments go, all right? And it's very difficult because remember, take that deep breath again, please, but this time force it out. Take another deep breath, please, and then force it out.
That's up, dude.
People with COPD and emphysema have to do that with every breath they take. All right, it does get exhausting, and it also burns calories. So I can tell you, like when we talked with COPD, Betty Fredericks, she was like a second mom to me. And she was a smoker, and she was a woman of size and substance, and I loved her dearly. But by the time she asked me to put my arms around her, because she was pretty honest, and this is probably the last time you'll see me, she was down to probably 98 pounds. And she was on oxygen tubing about 50 feet long as she moved about the house. And she had COPD. But because of the effort of that deep breath in and then pushing that breath out, burned so many calories, it exhausted her because you're constantly breathing in and out under duress. And the calories, she couldn't possibly eat enough to maintain body size because of the calorie burn. So remember that with patients with COPD, they're going to usually get thin and round chested, right? Because of the efforts. Now, the alveoli, right? This is where you actually do the exchange. Remember, there's 2 types, and this is testable material. There are 2 types of alveoli. One's the structure, and then the other is the type 2 production of the surfactant. What is surfactant good for? Especially working after your PEDS modules. So newborn babies, do they have issues with surfactant? Right, so sometimes we give steroids to mature the lungs quicker, but also sometimes you have to use artificial induction of surfactant, right? Unfortunately, for whatever reason, surfactant being introduced into the adult models when patients are having difficulty, the surfactant models don't work in the adult patients as they do in the children and the infant in particular. So we don't really have a remedy when the tissue is destroyed from either emphysema, COPD, or any other type of injury, especially with COVID now. Surfactant cannot be, we don't have a way to complement the lack of surfactant. So type 1 is the structure, type 2 is the surfactant production. Now those are academic factoids, but they're important. And here's the law of Laplace. This is simply understand that with surfactant, it allows you to have a larger surface pressure, space, where it doesn't want to collapse. Surfactant gives you the structure so you can have a healthy alveoli that will not collapse when you breathe out. When the respiratory exhale, if you didn't have the surfactant to the structure, the alveoli would want to collapse. And in emphysema models, it's exactly what is happening, right? Because the surfactant is reduced. So Laplace is why you're not going to be tested on that. Just understand that the surfactant helps create the structure for the alveoli to stay open and stay open when you're exhaling as well. Okay, are you good with that takeaway? I know it's like, oh, how am I going to do this? You know, but you don't have to this time. So gas exchange. So once we actually get the air to this point, the air has to go across and it's going to diffuse across. So you take that breath, that oxygen, remember everything wants to go from greater to lesser, right? Greater to lesser. So at this point, remember oxygen doesn't exchange one for one with CO2. The two are independent of each other. So CO2 is heavily on your hemoglobin, right? 4 units per hemoglobin unit. So the 4 units of CO2 are greater, and they're going to want to go off at the lung. And it just so happens when that CO2 goes off, oxygen has a place to get on because there's a lot of air in the lung. The lesser onto the bloodstream. That's where the exchange happens. So you know when patients have acidosis, that means the CO2 is probably being retained, right? So it gives less space then for more oxygen to get on, so your patient then can even become more and more acidotic because oxygen cannot be released. So we have to usually do something to make oxygen more attractive then, right? So how do we do that? What are things that you look at? Bicarbonate? Yes, because that bicarb will help buy some time and make the patient again a little more alkalotic, where it's going to be more favorable to the uptake of oxygen, right? Because CO2 is acid. So that's the part you guys did your ABGs, right? So 2 things you need to know about an ABG. Is it, now, first of all, we know acid versus base, right? Acid, base, that's how I'm talking. But the piece also then is if you're acidotic, what do you got to do? So, right, so that means it's probably metabolically driven. There's a point, though, where the patient may be septic or have other issues going on, where it becomes, instead of respiratory driven, it's metabolic. Did I say metabolic before I say? I'm sorry. Respiratory driven, and then, of course, if the system is not well, you become metabolic. And then the approach is quite, because you can hyperventilate a patient in just an early portion of it, respiratory. But once it's metabolic, it becomes more of a chemistry set for you to manage, okay? You're going to have to monitor. You may have to even ventilate the patient artificially to get the oxygen saturation where you need to. So you know the VQ. Now you'll see sometimes in patients, they may actually send a patient for a VQ CT scan. Because basically they're going to use contrast, and the VQ is ventilation, and what is Q? Perfusion, right? So you can see it's a pretty good machine. It's about 80% effective. For all the oxygen you bring in, about 80% of it plus is going to be utilized in the healthy model. So VQ should be VQ, should be pretty even movement. So when they do the scan, a lot of times in the CT, they're going to have contrast, and they're going to see uptake or not uptake as well. So you'll see the VQ. It's a radioisotope. Like when I was taking care of patients in Europe, in Germany in particular, VQ scans were not allowed. So an alternate you may also see is a spiral CT scan may get ordered. It's a fast spiral picture where it also can give some conclusive data on the ventilation and perfusion processes of the patients that can be reviewed by the radiologist in internal medicine, particularly pulmonologist. You don't have to do this other than know that these orders are coming and know that we are looking at ventilation and perfusion issues of our patients. Are we good?
Yes.
Remember, you're on your way to becoming licensed providers here, folks. So this slide, you saw it before, you're going to see it again. Now you have to understand, it's a different approach than when you saw it first time in PATH. Now you have to understand there's 2 things. The first, the upper left is your normal VQ. You see blue and the red is even in this graphic. See that? Appreciate it? So blue obviously is going to be the CO2 blood, and then it perfuses over and gets onto the hemoglobin, and we get red as it goes back into the body system. Then go to the right side, which we have COPD and emphysema, you have impaired ventilation. So it's a low VQ. So perfusion is fine. The vessels themselves are fine. But it's the ventilation, it's the machine of ventilation that's damaged here. So they realize, so that's a low ventilation, Q standing alone means it's normal perfusion. And then of course there's the shunt. That's where it comes off completely. Again, it's a low, very low ventilation, but perfusion's fine. Important for testing, we're going to talk about it. This is now high ventilation, so the ventilation's absolutely fine. It's the blood network, it's the venous and arterial network that is disrupted. And that would be your case when we talk about pulmonary emboli. That'll be where the blood clot obstructs the blood from getting around a perfectly working unit. So everything's going to be normal or low VQ if it's about the lung tissue. If you see high VQ, that tells you there's something wrong with the vascular system instead that takes the oxygen, into the blood. Is that pretty quick and easy for you? Yeah.
Yes.
All right. So various mismatches. So you guys already went through your ABG. Was that last week? 2 weeks ago? Are you good on ABGs? Okay. So I'm not going to hit this slide again. Just know there's issues of ventilation and perfusion. So again, have you seen this?
Yes.
Hemoglobin gives up its oxygen as red cells travel.
Right? So what you need to know for this slide, there's a lot going on, is everything. No, what you have to understand is the acid side, so you have a right shift. So the center line, there's two pieces there, but there's a center line is your normal part of the curve. So when you get acidotic, what happens? So you have acute acidosis, which is anything below. Anything below? Right, so now we're in acidosis. So now we're moving towards what we call a right shift, which again gives you higher affinity for the CO2 than for oxygen. The right shift. So the left shift is just the opposite. Now you're getting alkalotic, in which is anything above 7.45. Very good, guys. So that, you'll see alkalosis. And actually a patient that's hyperventilating, has anyone ever hyperventilated before? Where their hands started to feel all numb and their face felt funny and you passed out maybe? And woke up with a wet spot? Because you got alkalotic. So it's not as big a deal. It's still a problem, but acidosis is the biggest issue, right? A right shift is acidosis, a left shift is alkalosis. Either way, we need to figure out what's going on with respiratory drive. Some patients may be put, to avoid alkalosis, may be put on a Venturi mask. Has anyone seen that before? Right, where we kind of mix the room air with oxygen type of thing and saturation to avoid alkalosis. That's where the Venturi mask will work. But the goal is to have that. The neat thing also to take from this chart is understand that the body's pretty resilient about maintaining a level of oxygen. Maintaining a level of oxygen to about 80-some%. Right? And then you see the drops off. That's when it gets dangerous. We stay pretty level all the way up to 85%. And then we do the drop, no matter what side, left side or right side. The fact of the matter is we start to get acidotic and becomes very hazardous. So that's why you can see on our patients, around 90% when we're monitoring them, is even on ABGs or particular pulse oximetry that you're watching, real-time monitoring. Anyone below 90, we start to get a little more concerned about wanting to supplement with oxygen and what type of devices we're going to use, because these patients would want for them to get acidotic and cause any additional duress. So 80%, 85% is really where our window is, but our interventions begin around low 90s. Low 90s. Is anyone taking care of COVID patients? Anyone have a family member that was at home on pulse oximetry? A lot of patients are sent home with their own pulse oximetries to watch and maintain, while they're at home for care. So that is why, as nurses, once you hit around 92, you become eagle-eyed in what's going on with your patient, because that saturation plateau will drop off drastically after 90%. We've got one going to the 80s, we start to get in a lot of trouble, okay? That's where we're going to be doing adjuncts, considering ventilation, considering different oxygen delivery systems, and also look at the patient's efforts, activities of daily living have to be spaced out. Maybe we also don't want to cause them to be oxygen starved. So a lot of different things as a nurse you have to be able to take care of. Now, respiratory changes with ages. All right, so as you get older, you can see the recoil and compliance is going to change somewhat. Let's look at that slide one more time, because it took me an hour to make it. Oh, jumped ahead. Okay. Never mind. So anyway, enjoy it. It goes from a little to an older guy. But the fact is, it doesn't have to be that severe. Remember, healthy aging is very different than patients that are just aging. Interventions, exercise, all these things as nurses we encourage our patients to do as they enter their geriatric years has quality of life issues to them as well. You know, and they'll say, oh, I'm 70, my lungs are horrible, I can keep smoking. Would you encourage that patient to quit smoking still? Right. They still can get much better lung function back if they quit smoking. There's no terminalistic piece. So these are things you have to look at. Understand the other pieces, and that's why you saw initially with COVID, anyone over 50 and 60 were at higher risk because of some of these issues right here. The autoimmune system's different, you don't have the cells, the mast cells aren't available at the same levels, so things are challenged, and this can cause some of the issues that allowed COVID to be a little more concerning for anyone over 50 or 60. So I sliced all that up and made that slide for you. Anyway, I'm not going to begrudge this. You guys went through adult one. We all know these things. This is just a reminder of knowing for testing purposes. These are also issues that have to be under consideration when you're assessing your patient's respiratory system. Now, let's take a break. Literally, and we're going to do another 30. Everyone want to push through to another 25 minutes?
No, it's a break.
No break?
Break.
Break?
Break.
No break.
Break.
You know what? You got to go fiddle. Go fiddle. You won't miss anything. We're recording it. Go peek. Oh, wait a minute. Victory, as you will. There we go. So if you got to go, go. You won't miss anything. You got to go that bad? You got, oh, you're patting. And I'm like, oh. Okay, so if you know what? Can you guys all get back in here in 5 minutes? Okay, let's just do 5. That way we kind of, you know. All right, now we're going to go into acute chest and the injuries that may occur. Are we ready?
Yes.
All right. So these are the types of things you'll see in the ER all the time, but nobody did it. But one brother was down in the basement with the other brother, but nobody threw that dart in that kid's chest wall. Nobody's talking. But the fact of the matter is, you probably got a little hole in the chest wall, and it's going to become, with oxygen getting into it, what does it become?
Thorax.
A pneumothorax, right? So it's closed. It's a closed and open pneumothorax. The one we use with that dart actually goes from outside in. That is an open pneumothorax, right? Because the outside air directly is going to come in contact with that pleural space and create that space. The closed is going to be, we'll talk about it when if there's like a bleb or there's a rip in the lung itself internally, and then it's a closed. Then we'll also talk hemothorax, or we do ribs, and so on. All right. So basically, we were showing, remember that slide? It's 760, and you breathe in, it becomes 758 until the air follows in. Well, this becomes a problem because now we have air collecting outside of the lung in that space, and it starts to press down on the lung. Every time you breathe in, air escapes into that pleural space, and eventually it can start to collapse the entire lung tissue, and we'll go into the extremis of it. It can actually compress both sides. So here's a nice example. Here, see that lung? And you can see that on the x-ray. You should also be able to auscultate that, because you'll hear more when you're percussing as well. When you percuss, and it's going to sound more like a drum. What's that term? Huh? Timpani, very good. So it's going to sound much more like a drum on one side versus the other. It'll be uneven from one side to the other. And you'll see different areas, different portions the lung may collect space. There's going to be different ways to get there. So right here, you don't have to be a radiologist to appreciate what you're looking at. So on the right side of that patient, that's the actual lung tissue. See how you just see the ribs and then just the whiteness, right? And then see the other side, you see the vascularity, you see that. That's what the lung looks like. So that side, that lung is completely compressed down to about the size of a fist or smaller. So that's a right side large pneumothorax. And if it's not corrected, we're going to talk about it, will turn into a tension pneumothorax, which will kill the patient. Because the pressure, the mediastinum will start getting compressed, where the heart and pulmonary tract is. So you can have spontaneous pneumothorax. That's where a person can just be exercising or first time I saw spontaneous pneumothorax, I was still paramedic and I was preventive medicine. I was enlisted in the Army, and Jack Walker was our PA. But he was a Vietnam era guy, cigar smoker, and he was in the bathroom. And he hollered out to me, kind of whispered, "Hey, Jim, can you come in here?" And I'm like, "No." You know, and he's on the toilet, you know, I didn't want to go in. He goes, "I'm serious." And I said, "So am I, sir," you know. Anyway, I went in, it turned out he was having shortness of breath. Got the ER to come up and take him out, and he had a spontaneous pneumothorax. So he had some friable lung tissue, so he took a breath. It had a small tear in his lung, and then the air started collecting and ended up having a pneumothorax spontaneously. Another one I'll show you that you have is the blebs. Yeah, I'll show what a bleb is. So, also when you have priority, when you start to think you see a patient, tall, do we have a tall, skinny male in this room somewhere? Tall, skinny, can you stand up for a second? Yeah, you kind of meet the profile, absolutely meet the profile. So I want you to do this with me real quick, so everyone can do a 360. Just stand next to me like this, ready? And then on the count of 3, we're going to jump up and then turn facing this way. Okay, ready? 1, 2, 3, jump. Great. Okay, one more time. 1, 2, 3, jump. Everyone see that? See his thorax? He's got a long, he's narrow, and he's long, right? So that's really important. If he comes in as a young guy, how old are you? 22, young. So with that said, thank you. Round of applause for our model control. So if that patient comes in with shortness of breath based on his profile originally, especially if you just say, I was just playing basketball, I started getting real short of breath, I can't get the breath. Sometimes you're going to have to think in the back of your mind, this could be a spontaneous pneumothorax because his chest ATCs and everything else, the pressures are extended. So they can leave an area where the lung it's going to have long processes and can make it more prone to a tear in or pneumothorax. It's just a profile. Again, is that 100% of the time? No. But he is someone, if he came into the emergency room to you as a nurse, and he says he's short of breath without any other history, you get behind in the back of your head thinking, I'm going to auscultate, maybe he has a spontaneous pneumothorax. And then also, patients that have emphysema, cystic fibrosis, of course, right, because of the stickiness of the mucus and everything else, and then tuberculosis itself. Also, tuberculosis has had an upsurge in the last 10, 15 years again, and what makes tuberculosis a problem is called a caseous deposit. It looks like dimes. It literally looks on x-ray like dimes on the lungs, so that tissue is scarred, and those scar areas and around it are also prone to cause spontaneous pneumothorax tears in the tissue. Right here. This is your chest X-ray right here. And there you are with a haircut. There you are. No, that Marfan. See that? That's Marfan. So patients with Marfan tendencies. Does anyone know anyone with Marfan's disease? I'm going to show you a picture of a basketball player. He was going to be #1 draft in the NBA. Isaiah Austin was the #1 draft for the NBA. He had Marfan's, and the reason he couldn't go pro. Because of the risk for cardiac and pulmonary tears. He made it all the way through collegiate career, so it didn't happen, but they would not clear him to play in the NBA, which really amounted probably to hundreds of millions of dollars of personal loss because of Marfan's, which put him in the extreme case. You're just a tall, thin guy, then it turns out when you look at them, they're much more prone to rupture, aortic rupture, and also pulmonary ruptures and causing pneumothorax. Now the other pieces, and this is where I started to see a lot of this, are the blebs. They're literally like blisters, little air pockets like aneurysms, but aneurysms on the lungs, these big air pockets collect, and they're like little balloons and they pop. So the treatment for that is if the patient comes in with bleb. Anyone ever have bleb and had spontaneous pneumothorax in the room? Anyone spontaneous? So what they'll do is they'll open up with a scope, they'll go in literally, and you know how people like to pop bubbles? for, like, from dry cleaners from plastic, right, to relax. That's what surgeons do. They pop bubbles, they go in there and start relaxing, but they actually pop all those blebs with a tool on the lungs to go ahead and get that out of the way. Leave a chest tube in so the lungs can heal, and then the blebs hopefully will be taken care of and they shouldn't have any reoccurrences. So this can happen from completely normal lungs in particular. It can also happen with smokers' lungs. But you will see this, I saw this on 20-somethings, even younger, like in basic training. Kids would come in with shortness of breath, and after they worked them up, sure enough, they had like these blisters and blebs, and they would do a couple days in the hospital and then release back to training. Now, the open again, this is where we're going to be talking about trauma. Open pneumothorax. It's where patients either get shot or get crushing in a motor vehicle collision or in a fight. Drew Brees in particular, we'll talk about that with flail chest, but this is when it is open. So there's something that causes the tear from his tissue on the outside in. So you can see the air literally is no longer from breathing in, but it's also collecting. Every time you take a breath, it pulls it into the thoracic space. These are a lot more disruptive and usually can escalate much quicker. So we'll show a sucking chest wound here in a minute. And then also with the tear, not only do you have air often, you have blood vessels that are disturbed, so now you have a hemothorax, you can have a pneumothorax, where the air and blood is collecting. And this is where you'll see usually a chest tube will go in, size 36. This is not testable, but that is usually a size. It looks like a garden hose. We'll put it in there to evacuate blood clots, and air will get put into the fifth intercostal space of your patient. So here, you'll see.
Nice.
Now, the first one I understand, you can get shanked by anybody, but I don't understand why you stand around long enough for someone to open up their pocket knife to get you the second time. I mean, I would at least try it around a little bit, you know, but, I mean, I'm not done with you yet, pull out your pocket knife and everything else, but. Now, a little piece of mechanism of injury. This is probably done by a dude on another dude. Women tend to be much more lethal. Traditionally, again, these are sways. Women tend to do the I hate you thing, and they get you up here, and it's much harder to help patients when they have tears in the upper vascular system versus, your turn to die, right? That one's easier to manage versus the I hate you. And those are just little tidbits of understanding. So this is probably one dude stabbing another dude. If a woman, it'd probably be 40 cut holes across the upper portion of the chest. So anyway, this guy, well, all these injuries are pretty survivable, even though they're bad. These are pretty survivable. Either way, we got pulmonary and most likely vascular issues. So anticipate you're going to have a hemopneumothorax for sure on these patients. And you're going to want to be able to do the stabilizing these patients. So clinical manifestations, absent breath sound. But remember, you have tympany with the air collecting, but you have air and blood. Now it's going to get dull, right? Because you're going to have blood in that space. So when you're going ahead and percussing, anticipate it's going to be very dull, right? Because the blood is collecting in that space. The blood is collecting in that space now. So the most serious type of pneumothorax is a tension. Pneumothorax tension and or air itself. The biggest issue for the tension pneumothorax is not longer that just that lung field down, but that air bolus starts to build and starts to compress the heart. You guys familiar with cardiac tamponade yet? Same thing's happening. Basically, it's a tamponade process to the heart. So it's losing space to be able to fill and eject blood, right? So now, in the tension pneumothorax, we have a clinical emergency. This patient will die in very short order if you do not have intervention. And the simple thing it is, it's a fifth intercostal space, and the chest tube, 90+% of these patients can be saved with the simple insertion of a chest tube. But initially, sometimes we may use a needle to decompress initially to buy time. We're going to second midclavicular space with a large bore needle just to get the air out and something a coffee can. And then we will do, most of the time, a fifth intercostal space with a 32 or 36 French chest tube. You don't need to know those things for testing. Just know, though, when you're in the room, that's exactly what you're going to be doing, okay? It's a team sport, saving patients. So here's a really, really bad double pneumothorax. This is the post-mortem. This patient did not survive.
Yeah. That's right.
You can see where the heart was, how compressed it is. So what you'll do right here is just drop a needle. Now I've only, in all my time in trauma centers, I've only actually had to drop a needle on a patient once. For the most part, your docs in the rooms that work, especially in trauma centers, can put a chest tube in almost as fast as you can drop a needle. So just be ready to kind of work as a team and get things going. But your things that you would look at for a tension pneumothorax are going to be a tracheal shift, left or right, depending on the side it's on. Also, like in congestive heart failure, what might you see with the vasculature of the neck?
Distension.
What? Right, so the blood vessels are going to be engorged because blood can't move through. So it will look like just like a congestive heart failure patient that way. And then, of course, your percussion and your auscultation are going to be confirmatory of what your issues are. At that point, though, it really should be an entire team. Your medical crew and your nursing crew should be hand in glove, working quickly to get the chest tube situation out, scalpel sets out, get everything going, and getting ready to put the chest tube in to keep this patient on the right side. Now, here you have modalities right here. We have these different pieces. Now, when if you have a patient in the field situation, they may come into you from paramedics. They may have a clear dressing on with tape. Remember, one side, a portion of that tape has to be open because what I'll show you in the next video of a gunshot wound, it'll allow the plastic cover will stop air from getting in. But if there's pressure, back pressure, you have to have a way to let the air out. And that portion not being taped down all the way becomes like a flap. It allows air to press out. When you breathe in, it compresses. And you'll see this in the video here. It's a gunshot wound. See the lung there, right? I'm going to show you the next one's going to show it covered up. See now how it works? But they have an edge there. See, there's an area where air is going to come out still.
You want to take a look at it without the...
Sure, I got a move going.
Oh, sorry.
Sorry.
So you see how it works, right? Does that help you visualize what that means? So it creates that gap, but air still, remember you have air in there, so you have to let that air, it has to be able to escape out. And then once you get the chest tubes in and everything else, they may do a surgical patch or just leave it like that until it heals. Different approaches to that, but the whole point is understand why you're doing what you're doing. You want to evacuate the blood and or oxygen out of that pleural space so the lung can re-expand and hopefully restoring pulmonary function. So here's the kit. Now I'm going to tell you right now, no, do not send me an email. This is a Houston, Baylor, thoracic, DeBakey influenced chest kit. So when you open up the kit, this is what it looks like. University Hospital, whoever their lead surgeon is, he dictates what their kit looks like. So each one is based on who the chief surgeon is in that area. This is a DeBakey influenced system in Houston. You will see certainly some of the things are going to be the same, but there will be differences. So if you're in the emergency room, either as a student or whatever, you still want to know what that kit's going to look like, what's in it before you need it for the first time. But you also, you're going to need it. You're going to need scalpels. You're going to need to be able to make a hole. You're going to need to be able to cut things. You need to be able to spread things open. You want to put a clamp on the chest. So all these pieces are important. As a nurse, if the patient's conscious, make sure, because a lot of times they're going to be so quick to want to get that chest tube in the patient, there's no excuse on a conscious patient not to get at least some form of lidocaine or anesthesia, anesthesia, local space on board. Because when you start to cut, they're going to want to pinch over and it's very painful. Yeah, it's a life-saving procedure, but there's moments that we can at least get lidocaine or something on board to block that area where they're going to cut, okay? That's a nurse. Because the young residents just want to get the procedure. They're pretty excited. Procedures are exciting. We're collective. We think holistically. This is a patient, not a procedure. This is a procedure for a patient. So we got to kind of advocate to make sure they're going to be as comfortable as possible having this procedure done. Here's just what it looks like. Oh. Should kind of show you pictures. So it's kind of the steps involved here, putting the chest tube in. He has a tension pneumothorax, so they're doing compressions on him until they go ahead and evacuate the blood and the oxygen. They're finding their spacing. He's still alive, but the cardiac issue, he's having trouble with cardiac. Now they can cut in.
Está controlado en estadio.
You'll see the bloody show coming out. Yeah, punch through. You see that? You gotta make the space. Now, put a finger in the device, the finger will stay in there until we take the feet up over. That's about a 30-degree French. Now, the nurse, you're on the other side of that too. You want to cross clamp on the back of that too, because when the blood comes out, your knee gets ready to connect. You do not want the bloody show on your shoulder. So it's clamped off on here. Watch the blood come out here in a second. There we go. So now we're evacuating the blood in the airway apparatus. And you can see it takes a village, right? So it's very resource intensive. Nurses and doctors hand over, fist on this. And mind you, someone's still got to monitor the airway. Someone's still monitoring vital signs. You're monitoring all these things while this is occurring. You just can't focus on the event. You have to be global. So it is pretty exciting stuff, but it'll wear on you after a while. So look at the ABCs, airway, breathing, circulation, right? So look at it again for these patients, things you're going to be thinking about for nursing diagnoses. You can go ahead and review these. I don't like to test you guys on nursing diagnoses. This is for clinical. This is a little cheat sheet for you if you have any of these patients. Come back to this. So your assessment, again, you have to be, the nurse is responsible for the assessment as the physician is. In acute cases, a lot of times you're going to be noticing these patients, especially if it's spontaneous, because it can happen. If a patient's on a ventilator, they might be fine, but they get barotrauma, they can have a tear because of the hyperventilation or the extreme of the ventilation can sometimes tear the lung. They may be your critical care patient that starts to develop a pneumothorax. You cannot wait for the physician to round in 3 hours. You need to be on it now, right? These are your areas. But watching SpO2, ABG to the serial, watching your pulse oximetry, constantly assessing and reassessing breath sound, and checking all the different areas, the neck, and checking the trachea, grabbing and touching that patient, auscultating and percussing. That is what you do, and you keep doing it. So it's collaborative care, chest x-rays. A lot of times chest x-rays can be done in bed. CT scans, you got to get the patient, even though they're very sick, has to go to CT. They have to be monitored. You have to have a team. You got IVs. You potentially have ventilators. So it's very complicated, but it's a collective and collaborative approach. Again, risk for infection. These patients, obviously, especially if they had like a gunshot wound, clothes. Remember, if you got shot through a shirt, fabric can be infused into the chest wall. Maybe portions of the bullet, maybe different parts. It went through like a wall. It can be plaster. It can be anything in there. So you got to watch for these patients having secondary signs and symptoms of infection also. So some of the things you're looking at, right? IV fluids, monitoring INO, Foley catheter, H&H. You're going to be doing serial blood work on these patients. It's very tenuous, especially in critical care, emergency room setting, and then maintaining these patients and moving them towards healing in critical care and step-down units. Actually, a lot more work to do there. Because this is where vigilance. Now, flail chest, right? So on this one, you're getting to see the picture. Remember when you look at a chest x-ray, you're seeing ribs twice. You're seeing them coming off of the sternum, and you're seeing them looping across the back where they attach to the spinal column. So you just have to see that you're seeing ribs twice. But you can see the ribs are broken there. See the arrows? That's the clue. And it can be missed sometimes. It's not easy to see. Radiology misses them sometimes, especially on cracks. We had a little old lady who had a flail chest that was missed. She just had a lot of chest pain. She had osteo, and she had had a really bad cough for 2 weeks, and she had broken her ribs. And she was sent out initially with Motrin and cough medication. And then radiology called and asked what ICU she was at. And we're kind of like, well, she's at home. And so we went and got her back. And she put her in ICU 1. That's where she went. But anyway, and she did. She didn't have to be put on a ventilator, but she definitely needed a couple of days of observation. So, multiple rib fractures. Let's just say 3 or more. This is where Drew Brees, you guys know who Drew Brees? He was quarterback for the Saints. He had multiple ribs broken. They actually used titanium. They used surgical intervention, put a titanium bracing on his ribs. Most of the time, we won't do surgical intervention, but there are surgical interventions to fuse the ribs. Sometimes we just put them in a position of comfort and keep on high flow oxygen. Because remember, it hurts when the ribs touch each other and they're broken. Patients are more likely not to want to take full deep breaths. So you have to encourage them, but also you have to maintain pain medication. You have to put them in positions of comfort as a nurse to make sure they're optimally set up and breathe the best. The problem with a flail chest is like with Drew Brees, a 380-pound man landed on him and broke his ribs. When you see him like motor vehicle collisions, think about the impact. The car hitting, a lot of times it's a T-bone. The car intrudes or the truck intrudes into the cabin, and that impact is so great that it's breaking the ribs of the occupant. So with that means there's a lot of other shearing traumas that occur. So there's a high fatality rate with flail chest. It isn't necessarily the flail chest, it's all the pressures of the rest of the trauma that causes the rest of the issue. So I'll show a picture of what, you can see that right there, it's a visual, but I have a short video I'll to show you again. With that you'll see it. And we have to figure out, it's called paradoxical breathing, where it looks like a teeter-totter. Instead of up and out, it looks like a teeter-totter, and it can lead to a very irregular and ineffective respiratory cycle. See that, how it's pulling in? The machine itself, the bones, aren't allowing it to expand, so they're trying to breathe out and pull in instead of lifting out. That's paradoxical breathing. He's got 3 broken ribs or more on the side. Can you appreciate that? Okay. Those videos help you guys get a better understanding. This is not to be salacious or exposing the patients, it's to let you see what it looks like. Okay, this is not an expose on look at these bad injuries. These are things that give you full visualization. So it's done with respect to the patient. These patients survive. Good news. Now the other piece is crepitus. Again, if you're auscultating, when you're listening, you can literally hear, different than the sandpaper effect, but you will hear almost like tree branches hitting a glass. You hear the ribs crossing over on each other. You can actually auscultate it. But the patients are not going to want to take full respiratory drive because of the pain. So 30-degree angle is also being in a position of comfort. There may be surgical intervention. So it's collaborative care. So this patient, a lot of these patients may need to be in a ventilator because along with the broken ribs comes the contusion. But the parenchyma of the lung itself is bruised, and it gets bruised, it becomes dense, and it becomes like capillary blood filled, so it's going to be hard to inflate on top of it. So a lot of times patients you may see in the emergency room seem pretty good, and then you go up there to follow up on the patient, you may see that they are on a ventilator for a day or 2. because the inflammatory process makes it hard to inflate the lungs because they're so bruised and heavy with blood. So these are some of your nursing diagnoses, just review those. Now, pulmonary emboli. Now, is this a high VQ or low VQ? High VQ or low VQ? Right, high, good ventilation, but now the vascular issue, right? So this is where you get the clots. So where does the clot come from? So let's walk through it. Let's just say you have a clot in your calf, and that clot breaks loose in your calf. Where does it go? What's the first entry into the heart? The right atrium, right? And then it pushes through from the right atrium into the right ventricle. And right ventricle, it goes to the pulmonary artery. And then what happens? Whatever the size of the clot is, it's going to lock. And that vessel, whatever that size of the vessel is, it's going to block it. Sometimes there's small pieces. A lot of times, like in the calf, it's like pieces of the clot start breaking off. Sometimes it's a really big clot. It'll go up, and it's called a saddle clot. We'll talk to that. So deep vein thrombosis, right? So here it is, and it works its way up. And it can also be in your arms and everything else. It's all going to go to the right atrium, right ventricle, right pulmonary artery, and then blocks whatever the size and diameter of that emboli is where it blocks off that portion of the pulmonary tract. So they'll have back pain, shoulder pain, shortness of breath. Sometimes they'll pass out. You may have cardiac dysrhythmia, especially if there's a clot circulating along in the heart that create problems while it's moving. And always be suspicious of unexplained symptoms. And this can happen to anyone, even top of the line athletes. But mortality and morbidity. So people die from clots. But that's the saddle clot in most cases, where it's so big it actually blocks off an entire lung field, where you cannot get vascular oxygenated blood to the lungs at all on both sides. It's a clot that lays on both sides, it's huge, and it sits there, and you can't work around it. But you can see most of them are non-massive. About 96% are going to be smaller clots. Patients still can be very disruptive, still can die from them, but it's the large one. Mind you, if it happens in a hospital, interventionalists, which are most of the time radiologists, sometimes can go in, break it down through a vessel, and sometimes can save that patient. But the patients with the saddle clots are usually at highest risk for mortality. The others, what we do as far as managing that patient, usually if there's a small clot, we assume there's big clots still waiting to happen, but they're still in the vessels, so that's where you don't want to move the legs around. You want to leave that person as still as possible, and then you're going to want to put them on a regimen of treatment. So Serena was coming back from Australia on the long air. It's a long air. Has anyone been to Australia? It's a long flight, like 20 hours. So coming back from that, probably a little dehydrated, and she ended up missing most of that following tennis season because she had small pulmonary emboli, and she had gotten a clot while she was flying. So additional risk factors: being dehydrated, being on a pill. There's a ton of different things. Smoking, hypertension. There's a plethora of these things that should have been covered when you were in health assessment. Part of your question is. So we'll look. Anticoags. Remember, anticoags are not clot busters. So when you put a patient on heparin, or you put them on any other type of a light chain, anticoagulant, remember, you're not allowing more clot to form. That's all the anticoagulant's doing. It does not dissolve the existing clot. Your system, remember, part of your cascade blood clotting system at the end, it starts to break itself down. So what you do is you allow any further clots to form, and then your body will break down in about 4 or 5 days the existing clot that's there. If we have to use a clot buster, that's a whole different approach, because then we dissolve all coags in the system. So heparin is an anticoagulant that does not dissolve the clot. It just simply does not allow more clots to form where your body breaks down the existing clot. Are we good? All right, don't worry about how many units per kilogram or anything else. Those orders will stand, and you have to look those up to make sure it's correct. You will not be tested on those pieces, but you do know anticoagulant does not break down a clot. It just does not allow further clot. So we can actually go in, they can actually surgically remove them, or with the thrombolysis where we actually break the clot. Sometimes we will use TPA and other types of kinase, different things we can use to break down the clots. Again, you just need to know that when we do that, recombinant tissue, plasminogen, that we are now blowing away the clots. Whereas an anticoagulant does not allow what? Further clots to form. Good. So we're going to do studies. And the biggest piece is, the real gold standard is the duplex ultrasound. The D-dimer and everything else will pull those blood and will make us suspicious, but the duplex ultrasound is the gold standard where they're going to come in and actually look where the existing clots are in the extremities, okay? We don't want that patient bending their legs a lot or anything else. And here's your nursing diagnoses. Again, review those. Know those are your cheat sheets for clinical. Now, asthma. We're going to wrap up on asthma. Asthma kills. Does anyone in here have asthma? Bad?
Yeah.
Real bad? You've been intubated?
No.
Okay, I mean, a lot of times patients have it. So, here we are. We're getting, there's some voiceovers on these too. So asthma triggers, okay? Remember, we all know asthma. Are we good with asthma? We're going to talk about the acute exacerbation. I don't want to slow walk you towards asthma because you guys should have that down pretty good. So it's an allergic response. So it's potentially life-threatening. Patients can deteriorate quickly. They look like fish. As a matter of fact, on their asthma society, they show a goldfish out of water trying to breathe, and that's exactly what a really asthmatic patient looks like a fish out of water. So we're going to have treatments. A lot of times, when you have crisis, is it because you didn't take your steroids properly? Is it because you kind of broke habits, you got dehydrated? Is that what causes your problem?
Oh, it's like allergens.
Huh?
Allergens?
Just allergy, but are you still maintaining your regimen? Still have breakthrough problems?
Yeah.
Okay, that's tough too. So he's compliant, but still, San Antonio by itself is pretty tough sometimes. So it's no joke. I just want to put that up there. Sidebar story is one of my colleagues, she was an LVN, and she was a loud laugher. I loved her, but I hated having her on night shift because when she laughed, all the patients would wake up and want pain medications and stuff like that, right? Now her son, actually they were a dynamic duo. We were in the South, so she performed, and her son performed in Atlanta. They hit big shows. They're professional performers too. And her son, because of, anyone ever been on stage? It's dusty behind the curtains, right? Real dusty, and he wasn't managing his asthma, that's what I was working towards. And the next morning, he woke up very short of breath. It was humid, and he goes, Mom, I can't breathe. She goes, well, get outside and find your inhaler. I'm out of inhaler. So he collapsed and went into respiratory arrest. And he died 4 days later. Because it was asthma, unmanaged. And by the time he got transported, got to the hospital, he'd already been shut down for so long, he died of end-organ and multi-organ disease because everything was shut down. So Vincent died, and I never heard Val laugh again. I never missed it so much after she never laughed again. And it was completely avoidable. It was manageable. And here the mom was very much on it. So asthma is no joke. And as nurses, resort to nagging if you have to. Make it more uncomfortable for those patients or family members not to be compliant than compliant. Make it suck more to be non-compliant. Not compliant. So things you're going to look at, it's hard to breathe. You can see it fills with mucus and it constricts at the same time. That's what makes asthma such a booger. Your airway's getting smaller and it fills with mucus. So you go from having a garden hose to breathe through to having a cocktail straw with pieces of napkin in it. patients with full asthma do panic. They're terrified because they can't get a full breath. So when you're looking at managing these patients, shortness of breath, dyspnea, wheezing, or stridor, the worst part about asthma is hearing wheezing or no wheezing. When you have no wheezing, we are now fully moving into respiratory arrest. Have you watched
Help
this
from the
video?
medical team,
Is
Chris's
the real
body
asthma?
may shut down completely.
Seeing tripod positioning? See the scaling muscles, he's using his neck,
The
his
breathing
chest.
tubes in Chris's chest are squeezing tightly shut and filling with sticky mucus, blocking his vital oxygen supply. If he's not treated soon, he will die.
This is a really life-threatening episode of asthma. Asthma is pretty common in our community, and most of the time it's not this life-threatening, but this one is quite serious.
Chris's allergic reaction has tricked his immune system into shutting down his airways, blocking vital oxygen to the rest of his body. The drugs are supposed to help the muscles around Chris's airways to relax, but there is a problem. The mucus stops the drugs from reaching his blood supply.
Trying to try and help that, but sometimes the lungs close down too much for this stuff to work.
Time is running out. Chris's body takes emergency action. His shoulders and neck muscles swing into action to help inflate his lungs. But even this is not working. As the pressure mounts, the team must find a treatment to get the drugs past the mucus. Chris is by no means an isolated case. 1 in 9 Australian children suffer from asthma, but for Chris, the situation is looking dangerous.
Chris is currently having Ventolin or salbutamol through a nebulizer, which he's breathing into his lungs. This acts on the muscles around the small airways and helps to open them up. Unfortunately, sometimes when the airways are very closed down, the salbutamol doesn't reach the areas that it needs to get to. The inhaled Ventolin is not working. Then we often will go to a different form of medication. Again, a relaxant for the muscles around the small airways, and it helps to open those airways up, and it's given as a one-off dose over about 10-15 minutes in severe asthma.
Inside Chris's body, the airways start to open as the drugs take effect. Air finally returns to Chris's lungs, inflating the 300 million tiny air sacs.
Chris, is feeling a bit better?
These positions.
At last, he can breathe.
Chris seems to be feeling a lot better now. The intravenous medications seem to have taken effect. He still is very tired because he's been working very hard with his breathing, but we're a lot happier with his clinical progress now.
So that type of video you wouldn't see filmed in the United States. Thank goodness for Australia, has different ethical rules, but it gives us a really good example of this. I mean, it was released by the family, but we wouldn't be able to film that here at all. But it really tells you saw how many nurses working rapidly to get this patient recovered. It does. When you have acuity like this, it takes a good multidisciplinary team, the physician, your PAs, your nurse practitioners, your respiratory therapists are going to be in the room, and the nurses are going to be in the room. And everybody has to be anticipated. You should be completely blown away. You should be, all those medications before the physician's calling for them, you already know the regimen. You need to be preparing, and you should already be on the ball knowing what's next. No surprises, yes. It depends. It depends. You want to get, obviously, you want to get the airway open. So what medication is going to get the airway open the best? Albuterol, because it is a what type of antagonist? Good. You guys remember. You guys survived for Boston. Congratulations. Anyway, so these are the things you're looking at. Also, epinephrine sometimes might be put online. There's different things to also get the immune system to settle down. You want to dilate. And then, of course, we're going to be using heavy oxygen and maybe even put steroids on. Remember, steroids are not immediate. But you're going to go ahead and keep that patient, because rebound. You get that patient turned around. The biggest problem with asthma is you think you've turned the corner, and also 2 hours later they get a rebound attack. So hopefully the steroids and everything else will start to gauge it down. And again, these practices, if you have a pulmonologist, university, larger facilities have pulmonologists, and they will have a cocktail. that they approve, that is their approach. And as nurses, you know, you want to definitely know those cocktails so you can anticipate the care, because it's rapid. The care of these patients is rapid. All these respiratory patients, for the most part, it's rapid assessment, rapid hands, rapid remedies, and sustaining, and constantly, vigilantly assessing this patient over and over again. So it's time-consuming, it can be considered exciting, but the stuff is literally, the team is saving lives. And if you can interrupt that process and keep that patient alive, think about the butterfly effect. Who knows what that patient's going to go on to do and touch lives, you know what I mean? And just be part of the process. And I hope you guys learned something today from this. And you know, I do kind of tongue-in-cheek and I goof around a little bit. But one thing I am serious about is patient care and outcomes. If you're safe, you can be corny, you can have some fun, because that's how you compensate. That's how the weight of the day doesn't crush you each day, is to be able to roll with it a little bit. But remember, patients matter. So here's some of the meds again. I'll walk you through this piece right here. I won't be testing you necessarily on the medications, but do know the cascade of effect and how we're going to manage these patients. Bless you. See, you didn't let that sneeze out. You could have spontaneous pneumothorax action. So here's some of your nursing diagnosis to read.
Wall outlet is not working, so they know. I don't know what that means, but they do know about it. So. All right, how are you guys all experts now on the VQ mismatch and shunting and A&P of the lungs?
Yeah.
Yes. Okay. Dr. Cleveland has some super fantastic slides. The presentation that he gave today is posted, but it's huge because it does have all of those super fun animations in it. So then you have the one for printing or looking at that. Hopefully, if there's something that you feel like you're missing, just let me know and I can whittle the file down for you to be a little smaller. So we still have 2 sets of slides to go over. In here, we're going to talk about acute oxygenation problems like pneumonia, and then we're going to move on to talking about acute respiratory distress syndrome. So here we go, pneumonia. We'll let you read all that. So we're going to kind of weave a case study through both of these. We have a patient and he's going to start out kind of sick, and then we're going to make him sicker, and is that a word? Sicker? More sick. His clinical condition will worsen. Okay, so we're going to take Mr. Cook along through both of these slide decks. So when we start off, we're going to be talking about pneumonia. Pneumonia is acute inflammation of the lung parenchyma, and it's caused, as you know, by a microorganism. And it is when your body's defense systems become overwhelmed and they are not able to compensate. And alveolar consolidation is when those alveolar sacs just kind of become overrun with mucus and liquid. Delicious. Okay, so there are 3 to 4 million cases of pneumonia every single year, but a third of those are over the age of 65. And it is the most common condition for which the death rate has not increased over the last decade, meaning that those older folks still have a very high morbidity rate from pneumonia. So there's a couple of different ways of getting pneumonia. The first one is aspiration, and that can be from a decrease in your coughing or a decrease in your epiglottal reflex. You know, when you take a sip of water and you start coughing, because our normal anatomy is able to deal with that. We're not developing pneumonia because we choked on our water. But some of those folks who have those systems that are overwhelmed, they may aspirate. Also, patients that aspirate may have a level of consciousness change, and therefore they're not able to protect their airway, and that's how they aspirate. Other ways, inhalation, microbes present in the air, and of course we're going to talk just briefly about COVID kind of at the end. And then spread from a primary infection from another area of the body. So maybe you have sepsis, or maybe you have some other infection somewhere else, and it travels to your lungs. So there are two different types: community-acquired pneumonia and then hospital-acquired pneumonia. We are really going to focus on the hospital-acquired pneumonia because this is the acute care class. We'll save community-acquired pneumonia for community. We are really going to focus too on the ventilator-associated pneumonia and then healthcare-associated pneumonia as well. And we really classify these organisms according to the causative agent. And I've got these here for you. I'm not going to ask specific about which enterococcus causes which type of bacteria or anything like that. But just so you know, again, the difference, community-acquired pneumonia comes from the community, that these folks are not hospitalized or in a long-term care facility within the last 2 weeks. You can see the organisms there, and it's often treated as outpatient, depending on how severe it is. We use the CURB 65. There's a really great definition in your book that is not going to be on the test because that's in community or in acute care. So just so you know that they do use that CURB 65. But in the hospital-acquired pneumonia, it's a lower respiratory infection that usually occurs when the patient is hospitalized for 48 hours. Or a ventilator-associated pneumonia is developing of pneumonia within 48 hours of intubation. Again, you can see the microorganisms there, but knowing that these organisms can be drug resistant, and that is a huge, huge problem in treating these patients. Hospital-acquired pneumonia does have a high morbidity and mortality rate, and it has an expensive cost that is associated with it and extends the length of stay as these, when patients have organisms that are drug resistant. Okay, so our friend Mr. Cook. He's an older gentleman that is admitted to your intermediate surgical care unit with a diagnosis of respiratory distress and maybe some pneumonia. So when he rolls in the door, he is weak, exhausted, and he has crackles and dullness in the right lower lobe. So we were talking a little bit yesterday about percussion, and do you use percussion when you're doing an assessment? The lungs are a great place to use percussion because you can really hear the change from the top of the lung where there is no mucus buildup to the bottom of the lung where there is mucus buildup. So that's a great assessment strategy to use for the lungs. So he is dyspneic with a respiratory rate of 28. What does dyspneic mean? Like he looks like he's in distress, right? Not only is he breathing fast, but he really looks like he's short of breath. All right, so his stats are 88%, and he's on a 50% face mask. His blood pressure is 108/60. His heart rate is a little fast, but it's regular, and he does have a temp. Just as a note, Mr. Cook does not have any signs of any cardiac, GI, or GE problems. We are solely going to focus on his lungs for this case study. He also does have an IV in his right forearm. Yes, Mr. Cook. Okay, so he does have a history of hypertension. He's on an ACE inhibitor. He does have type 2 diabetes and takes medication for that. He also suffers from chronic bronchitis. But his main reason why he's here is he was hospitalized following a laparoscopic cholecystectomy, and he stayed in the hospital because he was having lots of nausea and vomiting. So before he came to you, he was experiencing generalized weakness. He kind of had some aches, chills, and a low-grade fever and a productive cough. So they called the physician and they did a chest x-ray that showed right lower lobe consolidation. So they decided to transfer him to the intermediate care unit because he was showing increase in that shortness of breath, increase in that dyspneic response. And he did have more sputum production, and again, that temp, and just kind of an overall kind of yucky picture. Very technical, yucky picture. Okay, so what are the risk factors that you see for pneumonia? What do you think? Age, right, for Mr. Cook. He was what, 83? An older adult? Okay, what else? Okay, did he smoke? I don't think, we didn't know that. What else? Okay, recent surgery. So these are all factors, but we're talking about which are specific to Mr. Cook. Right, he had a lap chole. Okay. Chronic conditions, he's got bronchitis and diabetes. Okay. Smoking, I do have smoking on there. And upper respiratory tract infection. We know that he has an increase in sputum production. Okay. So what does the patient look like when they have pneumonia? So again, those fever and chills, they just don't feel good. They have mostly a productive cough, and they might have some really ooey gooey mucusy stuff. Malaise, so that means that they're tired. You all have malaise, right? But this is like on another level, right? Like they are very tired, they're just kind of slow, not really moving around a lot. They might have some pleural chest pains from the inflammation of the lung parenchyma. They might have some tachypnea, so fast breathing, and then dyspnea, which means they feel short of breath. Crackles, rhonchi, and then again that dullness to percussion, which is a really great assessment skill. And of course, decreased SpO2 because now the alveoli are filling up with that mucus. So Mr. Cook, again, is that kind of older gentleman, and there are some kind of special considerations for our geriatric patients. They may have some altered mental status, maybe some confusion, hypothermia, they might be diaphoretic, don't really feel like eating, they're really tired, and they might have a headache. Okay, well, you guys already have these, right? Okay, so we don't need to have them fly in. So, what diagnostic studies would we think about for our patient that we're wondering if they do have pneumonia or is it going to progress to something different? So, of course, we're going to get a chest x-ray, and that's going to give us a picture of where that consolidation in their lung is and how far it extends. We might consider a sputum gram stain and culture, and this is going to tell us what antibiotics need to be ordered. We would do possible blood cultures as well to see if that infection has spread to any other part of their body. A CBC, again, we're looking for those elevated WBCs. We would check a C-reactive protein, and we would see an increase in that if we had some inflammation. Procalcitonin, so again, a pro-inflammatory marker. This would be elevated in folks that do have that inflammation. And of course, we would look at SATs and then some ABGs to look at hypoxemia. So, on the top, you have a normal looking x-ray. It's not too bad, right? There is some kind of like fuzzy white stuff on the top, but really not too bad. And then we have poor Mr. Cook here. What side of his lung has consolidation? Okay, it's the right lower lobe, right? Because when we're looking at the x-ray, it's like you're looking at the patients on the right side. Okay, so you really see that it is whited out instead of that nice black marker, and then he has some pretty significant consolidation. So when we're asking Mr. Cook about his meds, we would make sure that he had got his pneumococcal vaccine, and if he didn't, we would offer to give it to him. We would start some antibiotics immediately, and then we would adjust those antibiotics based on what our labs gave back. If they said that our sputum culture was sensitive to which antibiotic, or if we did the blood cultures again, what they would be sensitive to. But we start off with some broad spectrum antibiotics. We would give him some bronchodilators to help open up those airways, and mucolytic to kind of expectorate and cough out that mucus. We might give some antipyretics. What are antipyretics for? Fever. Okay, that's like a fancy word. I always am like, wait, I know this one. Yeah. So for fever, and then some pain medicine too. Sometimes that coughing really can cause some pain. We talked about a little bit of that yesterday. We are going to give him some oxygen to boost up his stats. We could give him some chest physiotherapy to kind of help lose some of that mucus again so that he can expectorate it. If we are going to do chest physiotherapy, we need to do that first and then give them mucolytics, right? So that they can cough them out. And then fluids to thin those secretions that will really help again to cough out and expectorate all of that mucus. We would position Mr. Cook to optimize his ventilation and perfusion. What do you think is going to be for him at this moment the best position? Laying down flat in his bed, in his hospital bed? Nope. Right. We want him to. Really the best position for him would be out of bed in the chair. If Mr. Cook is able to get out of bed reasonably with reasonable assistance, we would really want him out of bed to the chair. That is the most upright position that he can be in. If he couldn't tolerate that, we would get him up in the bed as high as we possibly could. But laying flat in the bed is like the very worst position possible. And then we would rest and mobilize, again, balancing to make sure that we weren't wearing him out too much, but we do want him to move around as much as he could tolerate. Okay, so when Mr. Cook comes into the ICU, he looks pretty terrible. He's weak, exhausted, he has crackles, he's got the dullness in that right lower lobe, he's dyspneic with a rate of 28. You see all of his vital signs there. He did get some Tylenol before he was transferred from the ICU, and what happened to his temp? It actually went up, okay, right, not helpful. When we were doing our assessment, we did notice his laparoscopic site on his abdomen from his lap chole, but they looked fine, no evidence of infection at all in those sites. And again, we had that right forearm ID. Question? You want to make sure that if you're going to do physiotherapy, that they have had medicine to cough it out, and that will really help to loosen up those secretions. So, you want to make sure that they have time to act before you start shaking them around. All right. Oh, question? Did I say that wrong?
No, you just said it backwards.
Okay. What you want to do when they have chest physiotherapy is make sure that there's time for the mucolytics to take effect. So, if you're going to have chest physiotherapy, make sure that there's something to actually shake loose and expectorate. Did I say that backwards?
Do legs first.
Okay. I said it backwards, please.
It's like, what?
Okay. All right. So the physician, when they roll into the ICU, they order an IV fluid, 75 mils an hour, again, to help thin out some of those secretions. And maybe we want to think about that blood pressure a little bit. Of course, we would calculate the map and see what that looked like. Mr. Cook, as a reminder, has no problems with his heart. Everything looks good. He has a little bit of hypertension, but he does not have heart failure, so we're not going to worry too much about giving fluid. We got the sputum gram stain culture and sent that off. The physician ordered some antibiotics, IV. He's on a 50% face mask. He ordered chest physiotherapy to that right lower lobe. We gave him some Tylenol, and we're going to try to keep that temperature under 0.2. And we're going to really encourage him to take as much oral fluids as he possibly can. So what nursing intervention would we consider for Mr. Cook? Okay, so of course we're going to use our excellent respiratory assessment skills, and we're going to update those often. We're going to do an assessment at minimum every 4 hours. We're going to watch his SATs, his vital sign. We're going to listen to his breath sound, look at his skin color. We're going to look at his sputum and watch his cough. Again, high Fowler's is going to, or semi-Fowler's is going to be best. Out of chair is optimal. Again, if his blood pressure can tolerate it, Mr. Cook is not looking so hot so we might not be able to get him to the chair. We're going to assist with CDB and IS. What the heck is that? Cough, deep breathe, and incentive spirometer. Okay, excellent. And we'll talk a little bit about incentive spirometer, actually how you teach and coach patients how to use incentive spirometer. We're going to administer oxygen as ordered. He's on 50% from his face mask. We're going to assist with physiotherapy. We would help the patient to lay on their side while respiratory is giving them the physiotherapy. Monitor ABGs and report any abnormal values, and then again, encourage fluids as much as possible, the thin secretions. We would give any medications that are ordered, provide for that rest activity kind of balance, assess his pain and give analgesics as needed. Think about activity. You know, we want him to be able to eat his breakfast, brush his teeth, but if he is huffing and puffing so much while he's doing that, that's really something to take note. And we would help him with any activities of daily living. And make sure, again, we're using that rest activity balance. Provide emotional support to both Mr. Cook and then encourage his family presence and help. Sometimes families feel really helpless when they have loved ones that are in the ICU, so if you can give them a job to do, it really helps to kind of facilitate your relationship. So what kind of jobs, really quick, would you have a family member do for Mr. Cook? Okay, spa treatments, yes. Okay, so we could help, wash his face, make sure he gets his deodorant on, brush his hair, brush his teeth, maybe he has dentures, make sure he's got those in. All of those kind of like normal activities of daily living. What else could they do? We usually don't have family do chest physiotherapy. Respiratory will do that. They have like a little, have you seen those machines that they use? It's a little handheld kind of thumper that they use to help. But you could encourage him to cough. Hey, when you get that stuff, really try to cough it out, spit it out for me. You could also encourage him to take in fluids. Like, hey, can I get you a drink? Could we try to drink this half a cup in the next, hour or something like that? Help him with his fluids. What else? Yes. Remind him to use the incentive spirometer. So how would you teach the family to use the incentive spirometer?
Every hour.
Okay. Use it every hour on the hour, and you can tell them while you're awake that I'm not going to if you're sleeping, I'm not going to wake you up to say, go ahead and use your incentive spirometer. So it actually is the breathing in and holding that is a really good part of the incentive spirometer. So sometimes patients, when they breathe, when they're using it, and you say, don't blow into it, you need to suck in and hold, because we're trying to open up those alveoli. Okay, so sometimes patients will go, you're like, okay, you're exhausting, you're hyperventilating, don't do that. It's the holding in really, really deep of those breaths during the incentive spirometer. So absolutely, that is a perfect thing to have family help Mr. Cook do. And then patient and family teaching. Okay, so just a quick side note, what about vaping? So, actually I had a student one time, I was proctoring a test, and the student, I thought it was like a recording thing. And I said, oh, you gotta take that off your desk. And they gave me a bunch of hassle about taking that off their desk. And I was like, okay, so you're gonna take a test. You're no need to record right now. And he's like, what are you talking about? Okay. So it's just kind of showing my ignorance. But anyway, for vaping, you can get actually a pneumonia from vaping, and it's because the fat content in the vaping mixture can get into your lungs. So we actually do, it's called a lipid-laden macrophage test, and that's how we would be able to tell if you, if you have a lipid pneumonia. And we would do this by bronchial lavage. So we actually give you some sedation and stick a tube down your throat, get a little wash to get some of the mucus from your lungs. And you really go about the same treatment for lipid pneumonia as you would for regular pneumonia. But what's interesting is when you ask patients, do you smoke? It's also usually assumed like that means vape as well, and they say no. And then when you get the results back, they have a lipid pneumonia, and you're like, oh, well, that doesn't make sense. And if you ask them, well, have you been vaping? And they say yes. Well, I asked about smoking, but you said no. Okay. So just a little bit about that. So also, what about COVID? So as you all know, coronavirus disease presentation shows up as tired, cough, with a fever, and some very serious shortness of breath and difficulty breathing. Folks with underlying medical conditions are at much higher risk for serious complications from pneumonia. So what should we do for all patients? Well, we really want to adhere to strict asepsis. We really want to think about the infection control policies that our hospital has set forth. We would do sterile technique when we do endotracheal suction or tracheal suction. Patients that have an NG tube or an OG tube, a nasal gastric tube or an oral gastric tube, we would make sure that their head of the bed is elevated, and we would monitor the residuals that they have from that. So how long, when you're intubated, do we put a NG tube in? What's kind of our rule for that? If you're going to be intubated longer than 6 hours is when we put that NG tube in, because your stomach is still producing acid and just waiting for some food to be dropped in there, and you know that you can have reflux, and that's how you aspirate and then develop that pneumonia. So if you are going to be intubated more than 6 hours, we would put in, it's usually, well, an NG or an OG tube. Patient with swallowing difficulties, we would make sure that they have a good cough and a good gag, and then we would help them with their oral intake. What directions can you give to someone who is drinking to encourage a good swallow? Tilt their head down, chin to your chest. Okay, so sometimes when you're giving these folks medications, the first thing I do is have them take a quick sip of water and see if they cough and sputter and how they swallow before I give them any pills, right? So have them do that, a quick sip of water, and then swallow those pills. And if they need a little bit of assistance, putting that chin to the chest can really help them have a good, nice swallow. Okay. So patients that have altered level of consciousness, again, we are talking about this patient, Mr. Cook, here in the ICU. We're going to position him to prevent aspiration, getting the head of the bed up as high as possible, and turn and reposition at least every 2 hours. I told you my story about 2 hours of positioning, right? No? Oh, I will. Okay. So where did the reposition every 2 hours, where did that come from? Why do we do that? Okay, so the theory behind it is so they don't get any bed sores, so they don't get deep tissue injuries, so they don't develop ulcers. But where's 2 hours come from? Our friend Florence Nightingale. So Florence Nightingale worked in a 40-bed unit, and that's how long it took her to go all the way around the 40-bed unit, 2 hours. So for some reason, we have still have this every 2 hours, we mobilize people, we turn them every 2 hours, even though there's virtually no scientific evidence behind moving them every 2 hours. So I do want you to think about, a lot of the things in nursing, it just rolls off our tongue, right? And it's like, well, gosh, where did that come from? Well, I don't know, we've always done it that way. So I'm gonna get on my soapbox for like 1 second, and then I'm gonna get off. But some patients need to be mobilized more than every 2 hours. Mr. Cook, frail, older gentleman, maybe he has taken some steroids in the past, maybe he has thin skin, maybe he's kind of like a little guy and he has lots of bony prominences. He might need to be turned more than every 2 hours. Now, if you put me in the bed, please don't bug me every 2 hours about turning. Okay, I'm fine. So it really depends on your patient for how often you're going to mobilize them. Okay, exit soapbox. All right. So mobilize as needed. Patients who are intubated and on the ventilator, we're going to talk about ventilator-associated pneumonia. This is pneumonia that is developed for patients that are intubated for 48 hours. So the intubation tube bypasses their normal airway defenses, and specifically that glottis, which protects us from aspiration. We'll get pharyngeal colonization from these secretions, or we might have contaminated respiratory equipment. It might not be sterile, especially if we have an emergent intubation. We do have pooling of secretions above the endotracheal tube cuff. Do you remember back to the beginning of the semester when we all did the orientation to clinical and you went through the airway rotation downstairs? You remember? I know, it's like super long ago, right? But did you like pull out the ET tube and see how it worked? Okay, kind of. So the ET tube is very similar to a urinary catheter in that it has a balloon that keeps it in place. So the ET tube, and I'll show you a picture on the next slide. ET tube cup is a balloon that's inflated by the glottis, and those secretions from your mouth are draining right on top of that tube. Sometimes the cup will have a little leak around it, and that's how you get ooey gooeys that drip down into your lungs. So they leak around the cup. So the idea is that you want to suck those secretions out as much as possible. Yes, aspiration around the cup, and your lung defenses become overwhelmed when you're intubated. So here's your ET tube right here. And so this is where the balloon is inflated. This is the balloon right here. Okay, and here's your glottis. So you get pooling of secretions right here at this spot that what you either need to suck them out or have the patient cough so that those secretions then come up into the mouth and you can suck them out from the mouth. This tube right here inflates the balloon. Okay, so that cuff. So if the cuff is not fully inflated or maybe lost some air, you might get some aspiration and some leaking of the secretions on top of the balloon into the lungs. So ventilator-associated pneumonia are those patients that develop pneumonia within 48 hours of being intubated, and it does have a really high mortality rate, and it increases length of stay, and often this pneumonia is drug resistant. So how do we prevent ventilator-associated pneumonia? The best thing we can do is wash our hands, and then we would check the ventilator tubing and make sure that if there is, because the air that is put in by the ventilator, who's seen a ventilated patient in clinical? Lots of folks? Okay, so the ventilator humidifies and heats the air that is coming into the patient, so you get some condensation in that tubing. And you want to make sure that the tubing and any liquid that's in those tubes is draining away from the patient. The tubing on the bottom of them has a little cup, and it's really fun. And it's something that you can do at the bedside. You don't have to wait for the respiratory therapist. You can suck out the liquid of the cup. It's like really satisfying to suck out all of that condensation. We also want to make sure that we don't instill normal saline into the ET tube. This is something that we used to do because we thought it helped the patient to cough and expectorate those secretions and also helped thin them out. Did you know that you can drown in a teaspoon of water if you get that teaspoon of water just in the right spot? Okay, and I know when I'm drinking, it's like a tiny little sip, right, that makes me cough, cough, cough. So we do not instill normal saline into the ET tube anymore, and you don't even see that. Again, bad practice. And we do want to try to use an endotracheal tube that has a dorsal lumen for suction, and that means that there's a tube that sits right on top of that cup that actually sucks out those secretions so that they're not pooling up there, because that is a known cause of developing pneumonia. So we have a ventilator-associated pneumonia bundle, or a VAC bundle. In this bundle are included things like keeping the head of the bed elevated at least 30 degrees, a daily sedation vacation. Why would that be in a VAC bundle? What are we testing during the sedation vacation? We're seeing if the patient is ready to be extubated, if they can breathe on their own, and what do we want? There's two things that we want them to do during that sedation vacation. Okay, we want them to cough, right? Because we want to see, if we had an ET tube in our throat, we would be coughing and hacking and gagging all over the place, right? Because that's not normal. So we're checking to see if they have a cough and a gag. And then the other thing is we're checking their neurostats. Because if a patient had a stroke or has some sort of neurologic problem, if they're sedated, we're not going to know because they're asleep. So that sedation vacation is in the VAT bundle because we're specifically checking their cough and their gag. And cough on demand would be best. We have peptic ulcer prophylaxis. Why do we need PUD prophylaxis?
Respiration.
Is this patient eating?
No.
No, because they're intubated. And what are you doing if what's your stomach doing even though you're not eating?
Making acid.
Still producing that acid, right? And we know that that acid can cause us to aspirate. So we would make sure to give PUD prophylaxis. And then what's VTE?
Venous thromboemboli.
Venous thromboemboli. So we kind of throw this in because it's a really good thing to do to make sure that your patient, because they are intubated, sedated, and laying in bed, that they don't develop any thrombus. Because where are the three places that if you have a clot, where do they go? Okay, the lungs, and it's called a PE. Dr. Cleveland just talked all about PE. Okay, where else do they go? To the brain, and it's called a stroke, and we're going to talk about that in a couple weeks. And then where's the last place they go? To an extremity, so, and then you would get a DVT, okay? So, and the heart would be so helpful is to pump that clot out to somewhere else, right? So we put it in the ventilator-associated the VAT bundle because it does have a respiratory component. We would do excellent oral care with chlorhexidine every 2 hours. Make sure that the mouth is nice and moist, and then brush the teeth. Has anybody brushed teeth on a ventilated patient? Don't be scared, right? It's easy, it's great, and they're actually asleep, so it's kind of like, you can really get in there. But brushing those teeth, you know, if you accidentally forget to, which you never would, but if you accidentally forgot to brush your teeth one day, how you get kind of that fuzzy stuff on it. So really, really important to scrub those teeth to make sure that you're getting all of that bacteria off and sucked out, because where is it going to go? Right into the lungs, right? Because they're just kind of hanging there with their mouth open. Draining in there. All right, don't be afraid of teeth brushing. So complications of pneumonia, you can see them listed here, but probably the most important one is in red, respiratory failure, and it is the leading cause of death from pneumonia. We're going to go on with Mr. Cook to talk about respiratory failure. The other one that's really important that we do have some more class content on is sepsis and septic shock. Okay, so one of the complications is a pleural effusion, and there's two different types. There's transidate and exudate. So transidate is just a watery substance that is in the pleural cavity, and we might need to use a what to drain that out? Chest tube, excellent. So the other one is a exudative, and it is really like pussy, high amount of white blood cell count. It's just kind of yucky, nasty. It's usually gray in color. These patients will complain. They'll be dyspneic. They'll have some pleuritic pain. Again, that dullness to percussion. We'll definitely notice it on the chest x-ray. I gave you an example right there. And it's really important for us to treat the underlying cause of these pleural effusions to get that fluid out, whether it's transidate or exudate, and then look at the need for a chest tube. One of the most ooey-gooey things that I've seen is a chest tube that like couldn't drain out the exudate because it was so tenacious, and it was like going in and out like at the top of the tube when the patient was breathing. Okay. So you remember all the stuff about chest tube management. It's important to ask the off-going nurse during handout why the chest tube was inserted and when. What did the output look like? What was the color? And are there any issues? Does it have an air leak? And you guys are all chest tube experts now. You've even been tested on it already, right? Okay. So we want to make sure that for the chest tube we're looking at the insertion site, and that we would start at the patient and then move down. We would look at what's in the collection chamber, look at the water seal chamber for tiling or an air leak, and then make sure that we had the correct suction, whether it was to water seal or it was actually using suction. Accidental disconnection, system breaking or removal, and then what we would do for any of those. Okay, this is my like ATI exam voice. What would you do? What are you supposed to do if the chest tube gets disconnected from the canister? Like, let's say you accidentally close it in an elevator door, or you trip over it, or the family trips over it, or something happens. What are you supposed to do? Okay, so show me your sterile water. Pull it out of your pocket, quick. Nobody has any sterile water. Okay. Oh, yeah. Maybe use some sanitizer.
Some coffee.
So,
Cold brew?
yes, that's what you're supposed to do, is get sterile water and put the chest tube in the sterile water. I don't know about where you all have clinical, but I know it takes a while to go get sterile water. So you could, for a brief moment, this is real life, this is not what you would mark on a test, okay? But you would clamp it very briefly while you ran to go get the sterile water, okay? And then we would assist with chest tube removal. So I practiced in Washington State before I moved down here to Texas. And in Washington State, nurses pull out their own chest tubes or pull out discontinued chest tubes. So when I took a travel nurse assignment down here in Texas, and I worked in a CVICU, and this patient, we were waiting and waiting for the surgeon to come back to pull out the chest tube, and I said, oh, no problem, I'll go ahead and pull it out. And they're like, oh, no, you can't. And I said, oh, yes, I can. I've done it a million times before. And they said, oh, well, in Texas, your nursing license does not cover you to pull out a chest tube. And I said, don't worry, I have a dual license. I've got one in Washington, too. But you want to make sure that whatever activities you're doing, your license does cover for your particular state. So just a good FYI. There are some differences. So in Texas, unless you're an advanced practice provider, you cannot discontinue chest tube. Don't worry, I didn't pull it out. I wanted to, but I didn't. Okay. Okay, so thoracentesis. So the purpose of a thoracentesis is we're going to remove some of that pleural fluid. Okay, that we talked about, the patient that has a pleural effusion, they have exudate or transudate. We want to remove some of that fluid, and we might be able to send some off to the lab for diagnosis, or maybe we want to instill some medicine or some antibiotics into that space. So before we do this procedure, because it is invasive, of course we would get informed consent. We would get a chest x-ray or an ultrasound to make sure that we knew where the fluid was, and also on the chest x-ray or the ultrasound it would give us some clues to like the tenacity, the thickness and thinness, what's that word? Viscosity, thank you. Viscosity of that fluid in there, so we could decide how big of a needle that we need to use when we're doing the thoracentesis. And we would appropriately position the patient. So what's this guy doing? Is this Mr. Cook?
No.
Probably not, okay, because Mr. Cook is not doing so well. So you can do thoracentesis as an outpatient activity. The patient would sit on the edge of the bed and fold their arms on top of the table, just like this. So the idea is that the fluid would collect in the bottom of the lungs and to the place that you're going to suck that fluid out. But for Mr. Cook, he is probably going to be laying on his side, and you're going to position him, the lung, the area that you're doing the thoracentesis, that's going to be down. So why would you need
Gravity.
it to be down?
Gravity.
So all of the fluid is collecting into that one spot, right? So you want it to be as dependent as possible. So the position is going to depend on the acuity of the patient. And then we're going to gather all of the equipment. A lot of times there's a thoracentesis kit that you will just grab, and we would assist. Of course, we are not doing the thoracentesis, right? But we are assisting the provider. Probably the biggest thing that the bedside nurse is going to do is what? We're going to monitor his vital signs, and what else? Pain management, right? Very, very important. We'll monitor the patient during the procedure, we'll apply the dressing, and then of course monitor them after. If they would like any of the specimens sent to the lab, we would do that. What complications are possible from a thoracentesis? You gotta do infection, sure, because we're sticking a foreign body in there. What else? Pneumothorax, right? You guys just talked about pneumothorax. So we would use that humongous needle and accidentally poke into the lung tissue. That's why we do a chest x-ray and an ultrasound before, to make sure that we know exactly where that tissue is or where the fluid is. Let's see. So during the procedure, again, we're monitoring vital signs, pulse ox, skin color. We're going to look for any signs of respiratory distress or increased work of breathing. We're going to take a look at that dressing. If we think maybe the patient has a pneumothorax, we would grab a chest x-ray really quick. And while we're waiting for the chest x-ray to come, we would pull out our handy dandy stethoscope and listen to lung sounds. What does a pneumothorax sound like? Trick question. Sounds like nothing, right? There's no sound because the lung is collapsed. And so we would want to make sure that lung is re-expanded. And then we would encourage deep breathing and coughing, again, to expand those lungs. So you can kind of see here the stuff that's coming out. So really there are two things here. So the first one is in this photo, they have a syringe, and they're actually pulling out some of the fluid, the pleural fluid that's in the chest right here, but then there's also this fluid. It's like chocolate milk, is what it looks like. And I have seen 5 liters pulled off of a patient. That patient could like hardly breathe. And we pulled off all of that fluid, and they could like actually say a full sentence and say their name. But boy, the chocolate milk, it kind of gets me. Okay, so I've got some resources here for you to take a look at if you're looking for any extras. We're speeding along, folks. You okay? Continue with acute respiratory failure. Got the objectives for you there. So acute respiratory failure is not a specific disease, but kind of a cluster of symptoms that affect lung function. It's a result of one or more disorders involving the lung or body systems, and these folks develop hypoxemia due to low oxygen or hypocapnia due to high CO2. Okay, so what do these patients look like that have acute respiratory failure? So they really have an inadequate exchange of their PaO2 and their CO2. So PaO2 is too low, CO2 is too high. We're going to look at their blood circulation because that's going to help us understand that PaO2 and CO2 ratio. And then the patient's ability to compensate. So poor Mr. Cook, his ability to compensate has massively decreased versus someone in this room, because we're healthy, happy, that we would be able to compensate for those low PaO2 or high CO2 states. So again, you remember the gas exchange, that we have the pulmonary artery that comes in, and is that oxygen rich or oxygen poor? Pulmonary artery. Poor, right? It's an artery, but it has poor oxygen. Okay, where's the other place in the body that is backwards, like artery means decreased oxygen? There's only one other place. Oh my gosh, and as soon as I said that, I'm like, what is it called? It's in a mom and the baby. What is that thing called? Yes, umbilical. Umbilical artery that goes from the placenta to the baby. right? Those are also backwards. That the artery has poor O2. Okay, fun fact. Okay, so the pulmonary artery comes in, it is oxygen poor. It surrounds the alveoli and you have the gas exchange where the CO2 comes in and the O2 goes out, and then it transfers to the pulmonary vein after it is well oxygenated. So there's hypoxemic failure and hypercapnic failure. So it's important to understand the differences between these. So the question is this patient in respiratory failure, are they having a problem with their oxygen, or are they having a problem with their CO2? So hypoxemic failure is oxygen failure. It's when their PaO2 is less than 60%. And even when you have FiO2 of 60%. So what is the oxygen that we're all breathing in the room right now? How much oxygen percent? How much oxygen percent? What percentage of oxygen? 21%, right? So patients that are intubated, we put them at least on 40% to help give them a little bit more oxygen. So these folks have less than 60 PaO2 on 60%. So what is normal PaO2?
80 to 100.
Do you remember from ABGs?
80 to
60 to 80?
no.
Right, is normal. Okay, so patients that have problems with oxygenations are those with ARDS, which we're going to talk about in just a little bit. Of course, the patients with pneumonia, Dr. Cleveland talked about those with massive PEs because the oxygen can't get there, right? There's a clot. Toxic inhalations, the inside of the lungs are coated with a toxin and they cannot do gas exchange. A shunt, which you talked about with Dr. Cleveland too, right? Yes, okay, good. Shock. Those are all ways of having low PaO2. Okay, so the next one is hypercapnic failure. So this is a ventilation failure. This is when the PaCO2 is greater than 45 and the pH is less than 7.35. You have an increase in the CO2 production and then a decrease in alveolar ventilation. So there's no problem with the oxygen getting there. It's just a problem with the CO2. So Dr. Cleveland also talked about asthma, right, and showed you some really great videos. These could be patients that have CNS issues, an opioid overdose where they have low respiratory rate, maybe a head injury, which we're also going to talk about towards the end of the semester. They might have some chest wall trauma or some neuromuscular problems such as MS, ALS, and Guillain-Barré disease. Okay, so some causes, again, of the hypoxemic respiratory failure. So there's a mismatch between ventilation, which is V, and perfusion, which is Q. The blood is shunting and really not participating in gas exchange. Gas exchange across that alveolar membrane is compromised due to perhaps some thickening or some damage to that membrane. And it causes the alveoli to be hypoventilated, right? Not getting enough oxygen. So you already looked at this picture with Dr. Cleveland, but I think it's important to understand the VQ mismatch. So on the top left, that's normal, right? You have good ventilation and perfusion. So when we go to the lower left, we have the blocked alveoli, and it's collapsed. So we have really good exchange, but there's no oxygenation there, right? So then when you have a high VQ mismatch, again, you have that dead space that really nothing is happening in that space. And then a low ventilation, low perfusion. You have impaired ventilation and hypoxia. So the hypercapnic respiratory failure, the CO2 levels cannot be maintained because of an increase in CO2 production or a decrease in those alveolar ventilation. It could be something that's been going on for a long time or a chronic condition, or it could be something acute happening as well. So what do these patients look like in respiratory distress? The first sign that you're going to see is some CNS changes. Okay, they might be restless, confused, agitated, maybe even combative. They're going to be really short of breath. They're going to have an increased work of breathing. They're going to be really tired. You might also see some retraction. Maybe they will have some dysrhythmias. Maybe they'll have hypertension and a high heart rate because they are just working so hard. These folks have the inability to talk in complete sentences, and they're just working really hard. So we're going to send these diagnostic studies. We've talked about all of these already. Again, that BQ scan, doing some hemodynamic monitors, and an end tidal CO2. So that's going to give us a quick reading of what their CO2 is doing at that moment. And then we're going to spend some time calculating a P to F ratio. So the PaO2 divided by the FiO2. So this is something that's really important and really easy for us to do at the bedside. So normal is going to be above 400. And then if we have acute lung injury or ARDS, we're going to have less than 300. So, for example, you and I, we're doing well, right? I think we're doing well, mostly well. So we check a PaO2 and we're at 101. Again, this is for a normal patient. And then our FiO2 that we're all sitting in here breathing is 21%. So when we're doing the P to F ratio calculation, it's going to be 101 divided by 0.21, because remember it's 21%. Okay, so when we do that math, we get 480. So hopefully all of us are around 480, we're doing really well, and we are normal. We're pretty normal. Okay. So then take, for example, Mr. Cook. Okay, his PaO2 is 85, and he's on 40%. So we take 85 PaO2 divided by 0.4, and we get 215. That's not looking so good, right? We're going to go into a whole discussion of ARDS, but you know that if it's less than 300, that patient is in acute respiratory distress syndrome. Okay? It is very important for you to know how to calculate a P to F ratio. Collaborative care. We're going to make sure that we treat the cause. So what is the underlying cause of this respiratory distress? Is this a pneumonia? Is there something that we can change in their shunt? Do they have a PE? Do they have a pneumothorax? So what is the underlying cause? And as best we can, we want to maintain their airway and ventilation. So we would give oxygen as needed, make sure that they have the appropriate position, and then monitor trends. So we would look at their ABGs and then, of course, use our really awesome assessment findings to make sure that we're doing the best we can. We're going to encourage coughing and their incentive spirometer, hydration, humidification, chest physiotherapy, and any suctioning. We might use some positive pressure ventilation, and that's going to help open up those airways so that they can be ventilated, right? Forcing those alveoli to be open. We would give the drug therapy, bronchodilators, mucolytics, possibly some steroids, diuretics, antibiotics, and then sedatives and analgesics, depending on the patient's situation. So our goal for these patients that are in respiratory distress is how do we optimize them as much as possible? So is it an oxygen thing? We want to make sure that we're giving and delivering as much oxygen as possible, making sure that their cardiac output is excellent, that they have enough little hemoglobin molecules carrying the oxygen to drop it off at the tissues. We might increase the oxygen administration, maximize their preload after load of contractility, maybe give some blood if they're needed. Again, that fluid administration, and PEEP. Have you guys talked about PEEP yet? PEEP stands for positive end expiratory pressure. I have a super amazing rabbit lung video that when we're on a break, I'll grab that video for you. But positive pressure, again, opens up those alveoli so that in a collapsed lung, you can allow all of those alveoli to participate and to be ventilated. So that's how we're going to optimize oxygen delivery. So we want to increase oxygen demand, right, the amount that the body is using. We would allow for rest periods, as quiet an environment as possible, treat their pain and fever, and then of course nutritional support. Okay, what puts the elderly at higher risk? So they have a decrease in ventilatory capacity. The lung is just getting old and doesn't have the really great elastic recoil that our lungs have. And they have a delayed response to those changes in PaO2 and changes in PaCO2. It's delayed. Whew. Okay, how you guys doing? Excellent. Okay, I'm going to grab the rabbit lung video so we can watch some more on the. I think I actually have it on the next slide deck. But we're going to take. What do you need? Watch that battery. In resources. So it's a really great way to help recruit. We're going to talk about some negative complications as well, but recruit those alveoli. Okay. So we are taking the patient that has respiratory failure and we're going to make him really sick. Okay, this is acute respiratory failure, and this patient is going to go into acute respiratory distress syndrome. All right, so you remember, I think I said he was 83. I'm sorry, Mr. Cook, he's only 82. Remember he had right lower lobe pneumonia, and he went into hypoxic respiratory failure about 8 hours after he was transferred to that med-surg unit. So currently, Mr. Cook, he's on an intermediate unit. He's got some normal saline running. He was at 75, now he's at 100. He's on that 50% face mask. He got a couple of doses of his antibiotics, some Tylenol, and we staggered him on a couple of steroids. He got 2 breathing treatments, and he's also had some chest physiotherapy or chest percussion several times since we transferred him to kind of help mobilize all of that pneumonia mucus. Okay. So while he was on the intermediate unit, his condition got worse. And over the next 12 hours, these are the vital signs. So his blood pressure has gone down significantly. His heart rate is 110 and regular. Remember, he doesn't have any heart problems besides a little hypertension. His heart rate, I said is 110. His respiratory rate has increased, right? It was 28, and now it's up to 36. He now is at 86%. SAT, SaO2, on a 50% face mask. So he was kind of doing better, and now not looking so good again. So his temp is down slightly. It was 101.8, and now it's 100. But Mr. Cook is agitated, restless. He's diaphoretic, pale. And he's got crackles and rhonchi throughout the lung fills bilaterally. So what did Mr. Cook have?
Pneumonia.
Right lower lobe consolidation. And now we're hearing crackles and rhonchi throughout his lung fields. If we do not have a really good baseline assessment to know what he was before, we can't tell if he changed. So really important in your handoff to make sure that you get those really important assessment findings. So Mr. Cook is responding to stimulus, but he's kind of moaning and groaning, and he doesn't really have purposeful movements, and he's confused. So now, what is the nursing priority? You guys have this slide, right? So it's no, oh, you don't have it? Oh, good, okay. So we probably need to call a rapid response. Okay, this patient is too much to handle on our intermediate care unit. Do you remember, again, at the beginning of the semester when you were in skills fair and you talked about the criteria for a rapid response? What are those criteria? When the patient's getting worse, right? Okay, so the heart rate's going up or the heart rate's going low, their oxygenation status is getting worse, their blood pressure is getting worse, or it's getting too low or getting too high. So a rapid response is going to get us some more folks. Who comes to the rapid response that we really want in Mr. Cook's situation? Okay, respiratory therapy is going to come, and then who else? The physicians usually do not come to a rapid response. Who's the other person that comes that's kind of the in-charge person? ICU charge nurse. Okay, so they walk in and they're going to say, well, what's going on? What's going on? What's happening? Tell us about Mr. Cook, and then we will be moving Mr. Cook to another unit. Okay, so the rapid response team increased his oxygen to 100%, but his SaO2 did not increase. That's not looking good, right? Because now we're kind of out of options. He's on a face mask, and from 50% face mask, now we've gone up to 100%, but his SATs didn't change. We're in big trouble. His level of consciousness had significantly changed. His blood pressure was low, and he wasn't responding again to that oxygen. We transferred Mr. Cook immediately to the MICU, and within 2 hours, we intubated him and placed him on a ventilator. We got another IV and started some more fluids. We also placed an arterial line and got some ABGs, and we got another chest x-ray. So what is acute respiratory distress syndrome? So originally this was called Da Nang lung injury, and it was identified in soldiers in the Vietnam War in the Da Nang region of Vietnam. And it's a sudden progressive form of acute respiratory failure. So Mr. Cook was doing, okay, and then all of a sudden he got significantly worse within hours. It's characterized again by that acute onset and non-cardiac pulmonary edema, again, nothing to do with his heart. His heart is doing just fine. And then the disruption of the alveolar capillary membrane. So these lungs become very stiff and non-compliant. They are not expanding the way that a normal lung would. It's caused in two ways, either direct or indirect. This could be caused by some trauma or some sepsis, some microorganism, and it results in significant hypoxia. So actually the defining characteristic, I've got it later, is refractory hypoxemia. So the lungs are not responding to that increase in oxygen. So what happened to Mr. Cook? He was on 50% face mask. His SATs were terrible. We gave him 100% face mask. What happened to his SATs? They're still terrible, okay? So we have got a big problem. So acute onset, we mean something that's within 1 week of whenever the insult happened. We get bilateral infiltrates that we noticed from the chest x-ray, and that refractory hypoxemia. So refractory hypoxemia means that even when we give you more oxygen, you do not respond. Okay? You're kind of in this poor oxygen state the whole time. So, and you get that altered P to F ratio. So you know how to calculate P to F ratio, right? Okay, so you know that if you're 300 and below, that means you have mild ARDS. Below 200 is moderate ARDS, and then below 100 is severe ARDS. We've got some calculation practice coming up. Okay, so this might be an example of a person that has ARDS. So what should these lungs look like? They should be black, right? They should be just, you kind of just go, ooh, beautiful. But these, it's like they have there's a cloth over them. They've got those white infiltrates bilaterally on both sides, okay? Okay, so the etiology of ARDS, again, there are two ways. There's direct lung injury, such as the endothelium receives some sort of insult, and then there's a indirect, which sepsis is the most common cause, and it's when you have an infection somewhere else in the body, and then it's transmitted to the lungs. So it's often seen with SIRS, systemic respiratory response syndrome, and multi-organ dysfunction syndrome, and MODS. So SIRS and MODS. So the patients are tachypnic, they're restless, confused, They have apprehension. They're using these accessory muscles when they're breathing, those intercostal muscles, right? You can see really, it's like their shoulders are going up and down when they breathe. They're agitated. You're going to hear some crackles. And again, the non-cardiogenic pulmonary edema. So the patient has crackles, but they don't have any problems with their heart. Okay, they don't have any left-sided heart failure. But the defining characteristic is that refractory hypoxemia. So their PaO2 is 60% on FiO2 of 50%. So as you increase the FiO2, their PaO2 is not increasing. So your PaCO2 is initially low, and then as it starts to build up, you're going to get an increase in that PaCO2 number. So your PF ratio is going to be less than 300. I showed you a picture of what the chest x-ray looks like. Again, that whiteout with bilateral both side infiltrates. And you have a decrease in compliance. Again, the lungs are not that stretchy material that they should be. These patients are going to require intubation, and they are going to need some sort of positive pressure ventilation where we're forcing volume to open up those alveoli and those very stiff, non-compliant lungs. Okay, so there's oral intubation. We can get real fancy. Oral intubation is just in their throat. You actually can ventilate both lungs separately. So if you want to do a double lumen endotracheal intubation, so you have basically you're controlling one lung with one ventilator and one lung with another ventilator. Again, it's getting really complex. We actually also can nasally intubate patients. This just like pains me because their poor nose, like think about sticking a giant tube in your nose. But it's normally the patients have had some sort of trauma that they would have to use that nasal intubation instead of the oral intubation. So what is the nurse going to do for these patients? They're going to insist with the insertion of the endotracheal tube. You're going to think about making sure the patient is sedated. If you or if someone is going to intubate us and we haven't had any sedation, what are we going to do when we try to put that ET tube in? We're going to cough, we're going to fight, right? Because it's not something that's comfortable. And we're probably confused, so any explaining that you're doing is not really going to help. So you want to make sure that the patient usually is sedated and paralyzed for the initial insertion of the ET tube. We're going to confirm placement, and how do we do that? What's the fastest, easiest way that we can confirm placement at the bedside?
Breath sounds.
We're going to, chest rises, but we're going to listen bilaterally to make sure that we have the same amount of air on this side and the same amount of air on this side. Okay, so sometimes, and then we would make sure that we didn't intubate too deeply, and then we're like ventilating the stomach, right, and that the stomach is increasing, or the abdomen is increasing. But our gold standard confirmation of ET tube placement is a chest x-ray. So, of course, listen quickly at the bedside and then call for that x-ray. We're going to monitor their oxygen and ventilation status. We're going to work closely and collaboratively with our respiratory therapist to make sure that we have the ventilation settings that we need. Confirm tube patency. Make sure we have scrupulous oral care, brushing those teeth, making sure that the mouth is moisturized. Monitor for any ventilator-associated pneumonia. We talked about that already. And then make sure that we're talking with all of our colleagues, again, our respiratory therapist, the provider, and then the patient family. It is a really good idea to make sure that the family is aware of the situation. And sometimes, because it's acute and it's emergent, you might not have time to explain to them right in that moment. But it's a little traumatizing if you leave the room and you go to lunch and you come back and your loved one is now intubated and restrained. Okay, so we want to make sure that we're explaining as much as possible to them. Okay, complications of intubation. So we might have an unplanned accidental extubation. Okay, that's when the patient, or maybe you turn them or step on the tube or something happens and they accidentally get extubated. We want to make sure that the patient is appropriately sedated and that they are restrained. There are some specific charting requirements for your individual hospital on restraints. It is common practice, everyone who has an ET tube to be restrained. Even if they don't seem like they're confused or they seem like they're following directions, it's just really good practice. The only patient that I've had self-extubate was restrained and had family in the room. He like wiggled down somehow and like flipped it out. It was not, it's not good. So explaining to the family like, hey, we do not want the patient to like touch any of the equipment. We want to make sure that his hands are down there. And it's not because we're being mean, we're just concerned about safety. So if that ET tube, that inflated cuff, if the patient self-extubate or the tube gets ripped out for some reason, just the same thing as a Foley, right? That balloon is inflated and then you rip it out, lots of trauma, okay? Lots of inflammation. So the problem can be that you cause so much inflammation that you cannot re-intubate the patient when they need it. So very important. We've already talked about aspiration and making sure that cuff is all the way inflated so they're not aspirating slowly. And the importance of an NG tube or an OG tube, again, for stomach secretion? Stomach secretion. Gastrosecretion. Okay. And then subglottal suctioning, so having a tube right on top of that cup to suck out all of the secretions that are sitting right on top of that balloon. And we've talked about the VAP bundle and all of the things that are included in the VAP bundle. Okay, the two kinds of ventilation modes that you need to know for this class are assist control and SIMV. So if you think about the name of the mode of ventilation, it kind of makes sense. So assist control is when you set a specific respiratory rate, and they use this funny F when they're calculating the respiratory rate. And they set it with a specific tidal volume, which is a V with a T. And this is something calculated by respiratory therapy. For like your average patient, it's usually around 400 cc's or so. So 400 cc's for every breath. So the patient as soon as the patient initiates a breath, a full volume is given. So let's say, for example, our patient is on assist control at a rate of 12. Okay, so they're getting 400 cc's at least for 12 breaths. So these patients need to be heavily sedated. These are not patients that we're thinking of extubating anytime soon. Okay, but let's say for some reason we're doing a sedation vacation, or we're trying to wake up the patient, or maybe we just decided that they need more sedation. So every time the patient initiates a breath, the ventilator is going to give them 400 cc's of volume. So if the patient wakes up, they basically start hyperventilating. So you can imagine what it would feel like to be delivered a breath, and then another breath, and another breath, and another breath, and you really can't control it. And it's very uncomfortable. So you would only use assist control on a patient who is sedated, that is not taking their own breaths, right? Because the ventilator is doing all of the work of breathing for the patient. Okay, for assist control, you need a sedated patient, and every time the patient initiates a breath, they get that full volume. Okay, SIMV, synchronized, intermittent, mandatory ventilation. So it means the same thing. Let's say we have a patient who's on SIMV, they're on a rate of 12, tidal volume of 400. But now, as the patient starts to wake up, they are allowed to take extra breaths, but the patient controls how much volume they're pulling or not pulling, right? They're adjusting. So it requires a patient effort with their spontaneous breaths. So this is a great mode for a patient who you're weaning off the ventilator, or you're trying to see how well they would breathe if you took the ventilator away. So you will get at least 12 breaths a minute at a tidal volume of 400. So the patient isn't going to be apneic, right? They're not going to stop breathing, or they're still going to have some support of the ventilator, but the patient is allowed to increase the amount of work that they're doing, and the patient controls how much they get. Does that make sense?
Yes.
Okay, so which one do you use for the patient who's like waking up and you're maybe going to do an SBT, spontaneous breathing trial?
This one.
SIMB. And then AC, you're going to use for what
Actually, I
kind
had
of
a
patient?
patient with that.
A sedated patient, someone that you're not extubating anytime soon, you're just kind of hanging out on the ventilator, okay? Great. Okay, so Mr. Cook, you see his vital signs there. Here is his ABG, 7.33, PaO2 47, PaO2 of 58, bicarb 20, SATs are 83%. We looked at his chest x-ray and we saw those bilateral infiltrates. Okay, he's on a ventilator setting of AC, rate of 20, FiO2 of 80%, tidal volume 500 for Mr. Cook, and PEEP of 5. So peak end expiratory pressure, like the minimum that you can have is 5. And I showed you those little rabbit lungs, it goes all the way up to 40. So Mr. Cook is just like on a basic, it's basically like PEEP of 0, okay? We're not forcing any air in, we're just overcoming the pressure of the ventilator tubing. So he is on some norepinephrine, okay, that we want to help keep his MAP greater than 70. We are giving him some propofol to maintain sedation. This, you all probably know this, but this is the Michael Jackson, we called it his sleepy milk. The fun, not fun, but propofol has a very, very short half-life. So once you start the medication, the half-life is like minutes, seconds to minutes. It's if you're in the operating room and they're going to put you to sleep and they use that white milky stuff, that's propofol. And they say count backwards from 100. How far do you get? Like 199. It's really, really fast. So we are using propofol to help keep Mr. Cook sedated. He is on some antibiotics, and we are giving him some Lasix because we need to get that fluid from his lungs, those white infiltrates, we need to get that fluid off. So we're kind of getting fluid off, but we're helping to support his blood pressure with the norepinephrine. Okay, so let's calculate his P to F ratio. So what numbers do we use? Okay, we know we're going to use FiO2, and how much FiO2 do we have? 80%. And then what number goes on top? PaO2. So we have 58 divided by 0.8. What's that? 72.5? What do you think of that? How's Mr. Cook? Terrible, right? He is in severe ARDS because we are up to 80% ventilating him with a ventilator, and his PaO2 is so low. It's so low. Okay, we are in trouble. Okay, so what are we going to do? We're going to make sure that we maintain the airway. Again, Mr. Cook is intubated, and we're going to use positive pressure ventilation to help open up his alveoli. We really want our PaO2 to be greater than 60. We're at 58 on almost maximum ventilatory support. Okay, so we do allow these patients with ARDS to have permissive hypercapnia. Means that we tolerate a lower tidal volume, so we give much, much smaller breaths. because we are going to open up those alveoli with PEEP. Okay, so we're going to use some pressure controlled ventilation, and we also might use, these are just some extra fun facts, you don't need to memorize these. The inverse ratio ventilation, meaning that we have more inspiratory time to expiratory time, because again, we're trying to ventilate those alveoli, so when they're open, the inspiratory time, we're allowing gas exchange, versus expiratory time, we can keep that short. Those patients have to be paralyzed. It is extremely uncomfortable. If you just try it on yourself, you can. It's not good. It does help the patients in ARDS, but it's very uncomfortable. The other ventilation mode you might see is high frequency ventilation. It's like stressful to even be in these patients' rooms. These patients are ventilated around 40 to 50 times per minute, and the alveoli are just like oscillating. So they're held open with a great amount of PEEP, and then the respiratory rate is just oscillating so fast. I'm like get anxiety just like being in the room. But again, helping those alveoli to stay open to ventilate. Yeah. Okay, so positive end expiratory pressure. So the great thing about using PEEP to manage these patients in ARDS is that you help improve the VQ mismatch. You allow more oxygen to get into the tissues, and that you can recruit more of those alveoli for gas exchange. Again, going back to the rabbit lungs, you can see when they increase the amount of PEEP that you recruited, like they recruited all the way the whole lung when they really increased the PEEP. So, but nothing comes without problems, right? So the risks of using PEEP or positive end expiratory pressure is you compromise the amount of venous return. There's so much pressure in the chest cavity because you're holding open those alveoli that it makes it really difficult for blood to come back to the heart, right? You might compromise the pulmonary capillary bed, again, because there's so much pressure, you don't allow for good blood flow. You can hyperventilate those alveoli so much, actually, that they pop, and that's called barotrauma. The problem when you burst an alveoli sac, what have you done now? What have you done now?
Decrease the surface
Can you
area.
ever recruit that alveoli again?
No.
No. That alveoli is done so. So it is a very hard balance to find out how you keep those alveoli open, but they don't burst. So again, barotrauma, rupture of the overextended alveoli when you're ventilating them. So we use smaller tidal volumes and we allow for an increase in PaCO2 without getting too stressed out about it. Volutrauma occurs when those large breaths are used to ventilate lungs that are non-compliant, and it can damage or tear the alveoli. So again, we're going to use a smaller tidal volume or pressure, which is really the standard for what we do for acute respiratory distress. Okay, here's where I knew I had it here. The picture of the rabbit lungs, so you can watch these videos both for PEEP as well as ECMO. What is ECMO? Anybody at Methodist in the CVICU? You guys see some ECMO there? Yeah, lots and lots of ECMO. So what they do is they take the blood out of your body, they oxygenate it, and then put it back in your body. So we use mechanical devices to kind of do the work of breathing for the lungs. It's like a super deep rabbit hole to watch these full videos, and you know how one plays right after the other?
Did you see it?
It's hours. Okay. But I don't have time for this because I haven't watched Yellowstone yet. You guys watching Yellowstone?
Oh yeah.
Yes? No? I know, there's only one. I know. I'm from Montana, so I'm like, feel like I'm right. Okay. So other alternatives, we talked about that high frequency ventilation, right? Those a really, really fast rate at a really low tidal volume. ECMO. Another thing you can do is inhale nitric oxide, and it causes some vasodilation of the alveoli tissue beds. The problem with nitrous oxide is it's very, very expensive. And it looks like a rocket tank that the patient has beside their bed. There's been some evidence that nitric oxide does really help, but again, it's usually used too little, too late, and it's very expensive. We do want to make sure that the patients are vented or sedated and potentially paralyzed. We don't want the patient to be trying to fight the ventilator, so they're trying to breathe out while the ventilator is trying to breathe in. So we want to prevent that ventilator dyssynchrasy and promote comfort and rest and decrease anxiety as much as possible. We're going to use our good drugs to do that, and again, using the neuromuscular blockade to paralyze them. So, position strategies. So see, we said turn frequently. These patients might need turning much more often. So, and we're not turning them from side to side as much as we're turning them from front to back. Has anybody seen a prone patient? Yeah, it's kind of crazy, right? We actually use these really amazing beds. We even have one downstairs in the CSI. In your spare time, you can hop in and put your seatbelts on and get flipped upside down. Kind of fun. But what these beds do is they allow the nurse to very easily control turning the patient. I know at Methodist, they do have manual turning teams, and actually for COVID, there's been a lot of proning in patients that have shown to help. The reason is because what's on the front of your lung? Think about the anatomy. Think back to Dr. Cleveland's lecture. What's in the front section of your lungs? This other really important organ. Okay, so the heart is there, and it's taking up space, right? So if you flip the patient on their stomach, now you have all of the infiltrates, all of the fluid kind of going to the front of the chest, and we've opened up this big space on the back. You have more alveoli on the back than in the front. So we can recruit all of those extra alveoli on the back. The problem, or what's hard about proning patient, it's very labor intensive, especially if you're manually proning. And there's these patients are never like, oh, they just have one IV and it's totally fine. Right? They have a central line, they have an art line, they probably have a femoral line, they've got all sorts of stuff. But in this roto-prone bed, you can just turn the patient over with a push of a button. Super awesome. Also, if you need to clean the patient for any reason, there's like a back hatch that's like right by their thumb. And the patients sometimes get really hot, and so you can like open up all of these like kind of windows to help the patient not be so warm. But the problem with these beds is they're super awesome, but they're really expensive. So a lot of times, it's just really, and there's only a limited number of them, so there can be a challenge to get. Okay, so we're going to turn from supine to prone or rotate in an extreme lateral position. So that means like all the way up. What degrees is that? 90? Would that be 90? Not sitting up in bed. So if I'm laying in bed right now and I'm going to turn all the way over, and then I'm going to go back and I'm going to turn all the way over to this side. All the way on your side. 180? Okay, we're going extreme lateral. Okay. Extreme lateral. So these rotoprone beds actually do this as well. Extreme lateral rotation. And the reason we're doing that is because we're trying to recruit more alveoli. So we're getting the fluid that's in the lungs to kind of move around a little bit and try to optimize ventilation and perfusion. Okay, we're going to make sure that we're using airway suctioning. We're going to use a sterile airway technique, and again, use diuretic therapy to help get that extra fluid off of the lungs. We're going to support perfusion as much as possible. We might need some inotropes to optimize cardiac output, and we may need some blood products to optimize hemoglobin delivery, right? We're thinking about supporting oxygenation as much as possible. And then we want to prevent any complications. We're going to give nutrition support, use the VAP bundle, BTE protocol, prevent any GI complications, and then use our PPIs. Okay, so look again at Mr. Cook. Okay, so we calculated his P to F ratio, right? And what do we get? 70, oh, I think I have it. 72.5. Really terrible, right? He is in severe, severe ARDS. So what kind of orders are you going to expect from the provider? Do we need to go back? Okay, sure, we could maybe increase our FiO2. We don't have too much more that we can go, but we could go from 80 to 100. What else do you want to do for his ventilatory setting? Increase the PEEP, right? So maybe we go from 5 to 8, 8 to 12. Okay, 20 is the max. And while 20 is super awesome, it comes with some risks and some side effects. Okay, so we gotta find the sweet spot for Mr. Cook to figure out where that is. We could also increase his rate, right? And decrease the tidal volume. So he does have a tidal volume of 500. Maybe we take it to 300 and increase his rate from 20 to 28. We are not doing that. We're collaborating with our friends at Respiratory Therapists who are the experts to do that. Okay. What else do you want to do? Maybe change the mode. We just talked about that. In decreasing the amount of tidal volume and increasing the rate. Okay, so what are our number one priorities? What are our nursing priorities right now? Panic. No, don't panic. Okay. You want to increase the oxygen to the tissue. So maybe we look at hemoglobin, maybe we give him some blood, not necessarily because his H&H is low or too low, but we want to optimize anything that we can do to increase oxygenation to the tissue. Okay. So other things that we would include, we're make sure that we maintain his airway. We're monitoring all his whole respiratory system. We want to make sure that we